Questo del nome lo conosci? Resta Caggi.
Ciao,
Ciao,
come stai?
bene, tu? A posto? Le notti che facciamo con piccolezzi.
Ancora non mi hanno scritto, Giuseppe. Ancora non mi hanno scritto. Vuol dire che proprio solo in anteprima. Sì. Però secondo me questa sera. Sì, tra stasera e domani. Tra stasera e domani ci sono.
Perché questo non è online. Ah, ok. Non c'è nessuno online.
Grazie mille.
Grazie.
Ci risponderanno venerdì. Domani. Sì, sì. Sicuramente risponderanno.
Grazie mille.
Cosa dice?
Grazie mille.
Sì, sì, ma non sarà difficile. Penso anch'io. Le domande di statistica. Principalmente saranno. Ciao.
Buongiorno. Dov'è che si cambia?
Venga con me.
Guardi qua.
Right now, I'd like to welcome you to this session, which is the first of this academic year. I am Francesco Bandello. I serve as the chair of this session, together with a lot of professors of our university. This is a bit crowded session. We have 13 candidates, and this is more than the number that we have usually. So we will need to be perfectly on time with each presentation and discussion in order to avoid that we have very long delay. We have theses in different topics. We start with Ettore Dattos. We will discuss the thesis together with Professor Emanuele Bosi. I don't see him. Perfectly, he is coming right now, and he is here right now, perfectly on time.
Perfectly on time, sorry.
No, you're fine.
Late.
No, you're perfectly on time. We need the chair for Professor Bosi. So we will start with Mr. Ettore Dattos. I was saying Professor Emanuele Bosi is the professor responsible for this thesis. So I'd like to ask to Professor Bosi to introduce the candidate.
Yes, with pleasure. Good morning, everybody. The candidate, Ettore Dattos, is discussing and presenting a thesis which has as a matter, as a topic, the development of neuro-microvascular complications in diabetes. And I mean, this is a very huge matter which has many, many things to be discovered yet. And in collaboration with the ophthalmologist of this institute within the Diabetes Research Institute and with the cooperation of Dr. Zerbini, that was investigated some neurodegeneration aspect in this complication. So I don't want to waste time anymore. Please go ahead.
Thank you for this kind introduction, Professor. Yeah, so welcome everybody. Today I will present.
We don't have the screen here.
Can you turn on the screen, please? Thank you. Okay, so today I will present this study titled Retinal Neurodegeneration in Capsular Diabetic Mellitus, a link between diabetic retinopathy and cognitive impairment. So I want to start with a brief recap on the natural history of diabetic retinopathy. As we know, it is one of the complications of diabetes. Therefore, at the onset of diabetes, we cannot appreciate any changes on the eye of our patient. After an unspecified time, but which ranges between 5 to 20 years, we can see the first signs of diabetic retinopathy, and these are microaneurysm. Later on, the disease goes on and becomes more severe, showing exudates and microhemorrhages that can lead to ischemia. And then the natural history of the disease brings us to the most severe complication, which is neovascularization in 10 to 15% of the patients. Once we reach this stage, we're only left with treating our patient, and we can either follow a medical therapy or laser photocoagulation. It is important to know that neovascularization is feared because it leads to blindness, and understanding the pathological mechanism leading to this disease could help us prevent it altogether. So we wanted to focus on the long time that goes before any signs are visible to the eye. And what we found in recent studies is that it's thought that in this time, diabetes acts invisibly on the retina, potentially causing neurodegeneration. So to understand these preclinical stages, we needed a different technique to address the eyes, and we now can use the spectral domain optical coherence tomography. This wonderful diagnostic tool helps us to see the little black square that you see in the picture, and it cuts the retina, showing us all the cellular layers we can appreciate on the right. This is an example of what an OCT looks like, and for this study, I want to focus your attention to this cellular layer called RNFL. This stands for retinal nerve fiber layer, and it is of paramount importance as it is the outermost layer, first of all, and the layer where the neurons or the retina reside. These neurons, I want to point out, are directly derived from the central nervous system. Therefore, there's a direct connection with these two tissues. So, as I already said, recent studies prove retinal neurodegeneration in diabetes, but they mostly confirmed it in type 1 only. We have three hypotheses on this matter. The number one, saying that neurodegeneration and diabetic retinopathy occur together. A second hypothesis from other authors states that neurodegeneration comes first, like we were postulating earlier, and then the diabetic retinopathy ensues later. And then lastly, we have the opposite way around. We have earlier a diabetic endothelial vascular alteration, which then causes an altered homeostasis of the tissues, leading to neurodegeneration as a consequence. Regardless of which one of these hypotheses might be true, we do have retinal neurodegeneration in all three of them. So next we asked ourselves, is the neurodegeneration a mere cause, as we said, of the diabetes through the vascular supply impairment, or could there be other mechanisms underlying this neurodegeneration? Recent evidence from a new paper that was published last year gave us a clear example
example of how a different route could induce neurodegeneration from diabetes. So in this picture I'm about to show you, we have a patient, a diabetic patient, which was undergoing an FDG PET examination. Prior to this examination, the patient took a shot of insulin, and during the examination, the patient felt hypoglycemia, and we were capable of seeing it in vivo and how it was acting on our neurons. So the way to understand this picture, we need to first understand the way the PET works. So by injecting a radioactive glucose compound, we can appreciate the tissues that is most metabolically active and uptakes this compound in red. These are the areas that are healthy and have a good metabolic environment. On the other side, instead, we have the black and blue shades, which are the tissues that are suffering because they are not capable of uptaking our glucose, and they're either very low hypometabolically active or they even could be dead. To better visualize this picture, we then need to mirror it and put it together with an MRI. And this is what we see here on the right. So the gray areas of the MRIs correspond to the healthy tissues that were red on the left, and now the blue and the black are portrayed as red and yellow. So we can see how in vivo this patient, just because she was in that moment in the state of hypoglycemia, neurons were suffering, and this could be another potential explanation leading to neurodegeneration. So where are we now? We already stated that recent studies of type 1 confirm retinal neurodegeneration, and we already know that type 2 is a risk factor for cerebral neurodegeneration. So we set for our study the aim to prove, first of all, whether there was retinal neurodegeneration in type 2 diabetes, and second of all, understand whether there was a correlation between retinal neurodegeneration and cognitive impairment in type 2 diabetes. If this correlation were to be proven correct, we could hypothesize to use the eye as a window of the brain in terms of diagnostic tools. So for our point number 1, we confirmed the retinal neurodegeneration in type 2 diabetes by studying 14 type 2 diabetes diabetic patients with retinopathy versus 14 healthy control subjects matched for age and sex. We analyzed our sample with the optical coherence tomography, looking at the central and the average macular thickness and the thicknesses of the layers of the retina, as we discussed earlier. What we found was there was no significant differences in thicknesses of the retinal layers, except for the RNFL layer, which is the one that we were talking about earlier. And we can see here our statistical analysis. After understanding this matter, we then proceeded to study our 14 type 2 diabetic patients to understand their cognitive impairment status. So first of all, we performed a neuropsychological evaluation. So far, we managed to perform a full neuropsychological evaluation in 5 of these patients. And the is that we did first a MOCA, which is a demonstrative cognitive assessment for dementia screening, a simple test performed in about 10 minutes that tells us whether the patient is cognitive normal or it could have a potential dementia. And then we performed the neuropsychological test battery and the clinical dementia ratings, other 2 clinical neuropsychological tests that are telling us whether the patient is capable of performing as a cognitive normal subject or not. The results of this neuropsychological evaluation were positive for us, as the MOCA scores was pathological in all 5 of them. As we can see, the normal MOCA scores are over 26, and all 5 of our patients were below this threshold. On the other end, NTB and CDR were both tests were normal in all of our patients. This set our patients in a borderline status, as they were neither cognitive, neither they were suffering from mild cognitive impairments. And this was very interesting, as we don't have studies on this stage of diseases. Lastly, patient number 2 and patient number 3, we were lucky to already have performed our neuroimaging, and we performed the FDG PET, like we said in the study before. So the results of patient number 3 is portrayed here, and it's interesting, but it also proves us what we already knew, that diabetes can and does cause micro and macrovascular complications in the classical model of disease. This pattern has been recognized as a clear vascular pattern, and we can appreciate just some areas of hypofunctioning in the middle cerebral artery regions. On the other hand, patient number 2 had striking results at the FDG PET, because as we can appreciate here, the pattern of the pathological pattern we can see is a clear pattern of neurodegeneration. This is very interesting as the patient is 68 years old. He has no symptoms, and it is one of the first cases where we can appreciate neurodegeneration on the PET, but we have no clinical correspondence so far. We want to keep in mind that the patient was set as borderline status, and he would need to be followed up in times to understand the progression of this disease. So in our study, there's retinal neurodegeneration in type 2 diabetic. The cross-sectional association between the retinal degeneration and the cerebral neurodegeneration cannot be ruled out just yet. And clearly, we need a larger sample size and follow-ups to confirm these preliminary results. If this correlation were to be proven correct, it would have importance in diagnostic and therapeutic future possibilities, as both diabetic retinopathy impairment, by tackling them together, could help the outcome of our patients. I want to point out that we were capable of performing this study as part of a bigger study, a multicentric European study that started this January. Term recognized, which has the same exact goals of what we already discussed, except that they're gonna follow up for 2 years, the cohort of patients across Europe. And lastly, I want to thank you everybody thank you all for your attention.
Thank you. It's really very interesting. I'd like to know if Professor Rosi or Paolo Zerbi, the comment or the questions first.
Just, I would, rather than a question, I would like to ask you your personal opinion. What would you privilege as a mechanism responsible for this neurodegeneration, about the many biochemical pathways and so on? Since this seems to be a little bit particular, what is in your mind? Data are very attractive, but patients are quite a few. So I would like just your impression. Where would you invest for a further understanding of neurodegeneration?
Thank you for this question. I believe that diabetes is a disease that tackles many different aspects of biology and chemistry and pathology. I think it's a combination of both, in type 2 especially, a state of insulin resistance together with a state of glucose imbalance. As we know, like the glucose range of our patients is never the same throughout the day, and this is why we are what we try to do is to keep it in that range. But the fact that it's not in, as we saw earlier, as hypoglycemia could cause a neural impairment, together with the coupled with the insulin resistance, this all together at the cellular level could make our neurons suffer. And in the long run, some of the neurons will be lost, eventually, potentially, generation, I believe.
Okay, thank you.
Gianpaolo?
Yeah. Congratulations, first of all. I have a question
concerning the second FDG PET, because it's quite interesting. Because when we show this picture to the neurologist and the neuroradiologist, they say immediately that this is an established pattern of Alzheimer's. patients should have major cognitive impairment. But as you have seen before, the neuropsychological tests do not fit this diagnosis. The patient has just a borderline cognitive impairment. There is a slight impairment with MoCA test, while the other more specific tests were all normal. So there is this intriguing discrepancy between morphology and a clinical pattern. And actually, the question for Ettore is exactly this one. This patient is a type 2 diabetes patient and insulin resistant from the human. So can insulin resistance affect the glucose uptake in these patients, and in particular may also have an impact on the pathogenesis of neurodegenerative diseases?
For your question, I do believe that there is a basis where we can understand that this patient is not
Suffering already clinically, because the areas highlighted in red here, they might not be that. They might simply not be uptaking the glucose tracer that we inject during the FDG PET. But we can also hypothesize that by this insulin resistance that blocks the uptake of the glucose, on the long run, would eventually make these neurons highlighted in red suffer. And we could hypothesize that maybe 3, 5, 10 years down the line, this specific patient already with this characteristic pattern at the FDG PET could eventually develop cognitive impairment. This allows us also to hypothesize about maybe therapeutic interventions such as insulin directed at the brain to make the neurons capable again of uptaking the glucose. And there's been recent studies in which patients like this, through insulin spray through the nose, improve their results on neuropsychological evaluation. So definitely we need more patients and we need more study, but this is a possibility for our future, I believe.
What about the therapy for the next time to become diabetic?
Yeah, this is a major point, because as Professor Perani said, this is a let's say, probably this is the beginning of Alzheimer's, but it's also a confounding picture, because what we are seeing is not Alzheimer's, but is insulin resistance in vivo. It's quite intriguing and quite interesting. We can usually we measure, we count insulin resistance using clamp. In this case, we are seeing, but the movement between insulin resistance to Alzheimer will not be appreciable by FDG PET, because probably this patient will stay with this pattern until the end stages. So at the very a good idea would be what they are already doing at this moment, to try to treat these patients with oral insulin or with insulin sensitizing drugs, to see if this pattern goes back. At this point, probably we can also delay the
appearance. So any question for? No, if this is not the case, thank you very much.
Thank you all for your attention.
So we'll meet later. As you know, we'll have an important yeah. No. Proclamiamo subito? Tutti? O per Bacco? E quindi perdiamo 10 volte il tempo.
Allora chiamate prima perché non fare il voto, eccetera. Poi
Mention. Visto?
Ah, l'hai visto quello lì o no?
Ah, la faccia del calciatore. Aspetta, mi devo... No, no. Ready?
Yes.
Okay. This is an important moment for you. So I declare that the graduate Ettore Datos has fulfilled all the requirements for the master's degree with the comprehensive final grade of 110, over 110 with laude and special mention. And by the virtue of the authority vested in me by the Italian law, I confer him the master's degree in medicine and surgery and license to practice. Congratulations. Bravo. Questo è il speciale dono che questo Ateneo riserva a chi ha fatto un percorso come il tuo. Figurati cosa prendono gli altri.
Non puoi venderlo, ha un microchip che è tracciabile.
Aspetta, facciamo una foto con la commissione, basta che ti
Non me lo puoi
Grazie.
Congratulazioni.
Bocca al lupo,
Bravo, congratulazioni, bravo.
Posso togliere il cappello che li sappia? Sì, Facciamo volta per volta. Il voto lo stai mettendo tu, tanto. Per cui io vado solo con la cifra.
Con comodo, non si stretta quello che...
Sì, no, adesso faccio entrare là. Possiamo procedere?
Yes, please. Yes.
Già lo facciamo girare.
Aspetta un attimo che questa dove c'è? Morning.
Good morning.
Morning. So the second candidate is Carmen De Martino, and she will speak about evaluation of combined fractional and excimer lasers with platelet-rich plasma for the treatment of vitiligo. This is a dermatologic thesis, and this will be discussed together with Professor Santo Raffaele Mercuri and Giovanni Paolino. Is everything okay? You are ready? Perfect. Dr. Paolino, do you want to introduce?
Yeah, I'm Special Professor Mercuri and Carmen, followed by Professor Mercuri regarding the treatment of vitiligo. That is a disease with not so many treatments, and that is, the treatment of vitiligo is a very challenging state, both for clinicians and for patients. And this is the first time that it's used monocyte PRP in combination with Fraxel and excimer laser.
Thank you so much for the introduction. So it is my pleasure to introduce you to this study that was done in the Dermatology and Cosmetology unit of San Raffaele Hospital, and in which we wanted to evaluate the combination of fractional and excimer lasers with the platelet-rich plasma for the treatment of vitiligo. So vitiligo is the most common depigmenting disorder of the skin with a variable prevalence in the general population between 0.4 and 4%, and it is a multifactorial disorder characterized by milky white macular patches with different margins due to the destruction of functional melanocytes. The etiology of this disease is unknown, and several hypotheses regarding the pathogenesis exist, including autoimmune, neural, self-destruct, and biochemical hypotheses. And also to date, a definite treatment and innovative strategies are currently under development. To date, the treatments are steroids, topical calcineurin inhibitors, UV-based therapy, and also surgery. Among the traditional therapies, we have excimer laser, which is a form of targeted phototherapy, and this device allows to deliver UVB radiation directly to the site that we want to treat, sparing the healthy surrounding skin, and it has a photobiological action. This device can be used alone, however, several treatment sessions are needed, exposing the patient to a potential carcinogenic risk, or it can be combined with other treatments, which leads to a shortening of the treatment course, reduction of laser accumulation, and improvement of the outcome of the therapy. Then we have also the 9027 fractional laser, which is a fractional thermolysis device with double abilities. And this, the particular wavelength of this laser allows to treat the epidermal and dermal layers of the skin, and it works by creating these microscopic columns in the skin surface, which are called microthermal treatment zones, that then stimulate the skin to collagen remodeling, turnover, and deposition. This laser has a low complication rate. In fact, the most common side effects are erythema and edema of the site of treatment. Among the innovative strategies, we have a platelet-rich plasma that is defined as the volume of autologous plasma that has a platelet concentration above the baseline. And the granules of the platelets contain different growth factors that can, in the context of vitiligo, promote the stimulation of melanocytes. The lack of a standard protocol for preparation led to the development of different platelet concentrates, which have been classified by Enfest et al. Based on the leukocyte and fibrin content in pure platelet-rich plasma, leukocyte and platelet-rich plasma, pure platelet-rich fibrin, and leukocyte and platelet-rich fibrin. Considering that nowadays in vitiligo we want to in the therapy we want to do we want to combine different treatments. We wanted to explore the efficacy of the combination of fractional laser, platelet-rich plasma, and excimer laser in the therapy of vitiligo through the evaluation of the vitiligo extent score at the beginning and 80 days after the first treatment. The vitiligo extent score is a measure of the extent of the disease, and it is an easy and objective way to assess it. In fact, it can be done on this website, vitigocalculator.com, and it can be done by choosing the picture that best resembles the extent of the disease in the different zones, and then at the end a score will be given. 27 in this study, 27 patients between the ages of 20 and 69. Recruited from the dermatology and cosmetology unit in San Raffaele Hospital, and patients needed to be off any topical therapy for at least 6 months and didn't need to have had any or fractional laser treatments in the past. Patients were excluded in case of low platelets, in case of celiac, thyroid, or systemic autoimmune diseases, and if patients were pregnant or lactating. A single lesion with a maximum diameter of 10 centimeters was selected for treatment, while other lesions were not treated. And the therapeutic program consisted in 10 sessions for each patient, starting and ending with a vitiligo extent score evaluation and photographical documentation. And the treatments started in the second session with fractional laser, then the application and injection of PRP, and then after 10 minutes, excimer laser. This was done on day 0, 7, 14, 28, and 49. On day 21, 35, and 49, only excimer laser was performed. The type of PRP used in this study was the monocyte-rich PRP that, compared to the standard LPRP, contains a lower concentration of inflammatory white blood cells. And in fact, we can see in this table that compared with platelets, an almost complete depletion of erythrocytes and of neutrophils, and a very low amount of lymphocytes, and it's rich in monocytes. This decision lied in the fact that these inflammatory white blood cells contained in LPRP can be detrimental to the reparative environment that we want to obtain in the context of vitiligo, because we want to obtain a microenvironment which the melanocytes can be stable and can also be proliferated. Concerning the statistical analysis, the vitiligo extent score in the first and last treatment sessions was performed, and the evaluation of treatment response was also performed by an independent physician based on a dichotomous assessment scale, which was characterized by the presence or absence of a repigmentation of at least 60%, and also a rank correlation to evaluate any correlation between the changes in vitiligo extent score and possible response to treatment was performed. At the beginning of the therapeutic program, the median vitiligo extent score was 0.65, while at the end it was 0.4. And considering that in this study we wanted to evaluate the treatment in a single lesion, and considering also that the vitiligo extent score takes in consideration not only the treated area but also the untreated areas, the general variation, the vitiligo extent score variation, was of course not significant. However, by performing the dichotomous scale based on the presence or absence of repigmentation for at least 60% for single treated area, we found repigmentation in 16 cases, that is 59% of total. And also patients were the same that showed a reduction of the vitiligo extent score. According to the rank correlation, a significant correlation was between the vitiligo extent score and the dichotomous scale evaluation of treatment was found. And also we found that the progression of the disease and the anatomical area does not affect the therapy outcome. Concerning the side effects, patients experienced only a mild local burning sensation and erythema that disappeared after 2 days. In these slides, I wanted to show you some vitiligo lesions before and after the therapeutic program. In the second picture, we can clearly see that it is repigmented. Also, in this picture, we can clearly see it. And so we can conclude that the combination of 9027 nanometer fractional laser, monocyte PRP, and excimer laser is an effective, safe, and well-tolerated treatment for vitiligo. However, I have to say that this study was based on a small number of participants, therefore further clinical trials are needed to confirm this observation. I also wanted to say that this was the first study in which this combination was performed in the treatment of vitiligo, and also in which PRP was used. I would also like to end my presentation by thanking Professor Mercuri for participate in this study and in his department, and also Dr. Paulino for the huge support given for this dissertation. And I would also like to thank you all for the attention.
Thank you. Thank you. Giovanni, do you want to say anything about this thesis? Any comment?
Yes, just one question. And first of all, okay, that's a thesis with a small number of patients. Okay? So there are several patients. And one question, do you think that other topical treatment may be used in different sessions? I mean, maybe topical immunosuppressive treatment.
Thank you for your question. I think that, for example, in this context and in this therapeutic program, besides fractional laser, monocyte-rich PRP, and excimer laser, also, for example, corticosteroids can be used in between the therapeutic sessions because we can, in this way, we can combine the immunosuppressant effect of these drugs and the regenerative effect of these techniques that we used in this study to achieve a better outcome and a better effect.
Any question? Please.
Population count. Wondering whether it's known that the nanocytes will have a certain
No, the thing is that with PRP and the growth factors contained in the alpha granules of platelets, these factors can have an interplay with the fibroblasts and the keratinocytes, which then, in the context of vitiligo, can promote melanocytes.
Any other comment?
Yeah. Quite interesting. Of course, I'm not familiar with vitiligo, but from the autoimmunity point of view, this is quite attractive. So how would you define the mechanism, as far as you can say, of action of your treatment? Would it be more a sort of regenerative medicine? Or do you think that also the component of immune modulation plays a role? Because, I mean, according to what you presented, these things to be more a pathogenetic therapy rather than a cosmetic therapy.
Yes.
But this is just an impression by
The dermatologist.
yes.
Of course, we do not want, we want to treat the disease through the pathogenic mechanisms. And even though there are hypotheses concerning the pathogenesis of the disease, nothing is confirmed too much. In this study, the monocyte-rich PRP and the fractional laser had a regenerative effect, while the excimer laser and the UVB rays instead not only, of course, this is something that it is hypothesized that the excimer laser has this effect because the UVB rays not only promote the melanocytes but also have an immunomodulating effect by basically killing the cells that are responsible for this disease.
So you think you can define or can imagine combination of effect, regenerative and immune modulating?
Yes, because with excimer laser we have an immunomodulating effect, which we can achieve also with the corticosteroids, and at the same time we can have a regenerative effect with fractional laser and PRP.
Very interesting.
Professor Martini? Thank you. Thank you very much. Wait a bit. Così?
Sì.
That's fine. Che accade? Ok, sì, però dovremmo abbreviare i tempi morti perché ci stiamo dilungando. So, morning. Congratulations. I need to take the. So, this is the official formula that I'm going to read. I declare that the graduate Carmen De Martino has fulfilled all the requirements of the degree with the comprehensive final grade of 108 out of 10, and by virtue of the authority vested in me by the Italian law, I confer her the master's degree in medicine surgery and license to practice. Congratulations.
Brava.
Arrivederci.
Arrivederci. Ah sì, giusto, giusto. Fateci sotto la maschera.
Sì.
Ok. Adesso dobbiamo... Prego. Hai ragione, me ne sto rendendo conto, dovremmo... Hai ragione, confermo. Moni. So we are now Lamberto Lafranca. Noi dovremmo collegarci con il... Così. Ci dovremmo collegare con il correlatore. Già connesso?
Accendere il microfono e parlare.
Sì, magari lo aiuta così siamo un po' più rapidi.
Okay.
Prendi da seggiola, ti siedi.
So the next candidate is Lamberto Lafranca. He's going to present a very interesting thesis on an ophthalmologic topic, voltage sensitive dye imaging for investigation of cortical responses to focal retinal stimuli and prosthetic vision. This thesis was realized in Israel, and I'm very happy to say that Lamberto was able to organize everything by himself, and we did not contribute a lot, but he was absolutely perfect. He was able to organize everything and to realize a very interesting work that we are going now to listen at. The other yes, professor is Federico Esposti. What is Federico? You must come a bit nearby. Yeah. And so please, Lamberto, go ahead.
Good morning, everyone. I would like to present you my final dissertation, which is voltage-sensitive dye imaging for the investigation of cortical responses to focal retinal stimuli in natural and prosthetic vision. In this project, which was, as said, conducted in Yossi Mandel's lab in Bar-Ilan University in Tel Aviv, we have tried to elucidate with a high degree of accuracy the cortical responses to different focal stimuli in the retina, and the cortical interaction that derived from such stimuli. But before showing what we achieved during this almost a year, I would like to elucidate a couple of concepts that are preliminary. The first one is the role of the retina in vision and the role of retinal degeneration. So the retina is the CNS structure that is responsible for vision. It does so, it's responsible for vision by converting a light signal into a neural signal, into an electric signal. And in this visual pathway, the first cells are the photoreceptors. Photoreceptors are paramount for our research because are the cells that are degenerated in different retinal degenerative diseases like age-related macular disease, for example. So, in fact, in AMD, the pathological hallmark is the degeneration of retinal pigmented epithelium and photoreceptor. But since the other cells of the other layers of the retina, and so the other cells of the retina, remain relatively intact in AMD, the role of subretinal prosthesis is exactly that one of the functional substitution of photoreceptors. How retinal prosthesis achieve that? They encompass cameras, computers, and electrodes in order to convert the light information into neural signal. In retinal prosthesis, the information about the visual scene is captured by the head-mounted, usually camera, is converted into near-infrared light and relayed to an already implanted retinal prosthetic device. Because skin-penetrating wires are not a feasible option because of the risk of scarring and infection, then the power for the electrode and the visual information must be conveyed wirelessly. And so, the latest technological advances in this field are electrodes, so implanted electrodes in the retina, that are made up of pixels that directly, each pixel of the electron directly converts light, which in this case is near infrared light, into electricity for further for conveying the electricity to the other cells of the retina for the integration of the stimulus. So, which were the aims of our project? We wanted to unveil with unprecedented accuracy the cortical responses when we presented the retina with focal stimuli, both in natural prosthetic vision and ideally a combination of the two. We wanted to characterize the phenomenon of lateral interaction and lateral inhibition in vision, which was previously investigated with not such accurate techniques. Previously was investigated mostly with visual evoked potentials. We wanted to see whether there were similarities or differences in this lateral interaction and lateral inhibition phenomenon between the natural vision and the prosthetic vision, and eventually this would have helped find a way to integrate retinal prosthesis and natural vision. Our experimental setup is very simple. There is a light source, which is a digital micromirror device. In the image is the DLP-DMD. The light is then conveyed to the retina, precisely to the retina of the rat, through a set of mirrors, which are M1 and M2 in the image, and lenses for convergence, which is L1 in the image. And so the light stimulus was precisely conveyed to the rat retina. We were able to assess that the light stimulus was conveyed to the rat retina because we actually had a camera that pointed directly to the retina, and is the camera on the L2. The cortical responses were recorded with the camera in red in the image, which was able to actually sense the change in fluorescence of this voltage-sensitive dye, which is a dye that is actually sensitive to the change in voltage and so to the depolarization. This is what we achieved. At first, we actually made a retinotopic mapping. So in A, you can see that we provided 8 different stimuli to the retina of the rat. And in B, you can see on the left the temporal responses and on the right the spatial responses. And in C, there is the actual production of the retinotopic mapping. As you can see, when we stimulated on the temporal retina, the response was anterolateral on the visual cortex. While when we stimulated on the nasal retina, the responses were posteromedial on the visual cortex. So it's basically, the map is the same, but it's with 45-degree angle. Then we wanted to actually see the phenomenon of lateral interaction. So we provided 3 different stimuli. On the left, there is the target stimulus. On the center, there is the collinear flanker stimulus. And on the right, there is the combination of the 2 stimuli, so the target with the flankers. In B, the stimuli were, the target and flanker stimuli were 300 micrometers apart and were large, just 100 microns. In B, you can see the actual responses, the spatial responses of the visual cortex to the target stimulus, to the stimulus of the flankers, and to the combination of the 2. In C, it's very interesting because you can see that actually we superimposed just the target and flanker stimuli, and you can see that there is no overlapping between the 2. So this is a further assessment of the extreme precision of this method. We then selected the regions of interest, so the areas that interested us actually, of the target and the flankers, to further analyze. This is a superimposition of the temporal responses on the left region of interest and on the right in the flankers region of interest, the responses to the target stimulus, which is in blue, to the flanker stimulus, which is in red, of the 2, which is in purple, and to the linear summation of the single target and flanker stimuli, which is in yellow. We understood that, for example, in the target ROI, which is in the left, the target stimulus elicited a stronger cortical response than the combination of the two stimuli. So this, our conclusion was that actually there was in the combined stimuli, there was a of the flankers to the target. While in the flankers region of interest, you can see that the flankers and the combined stimulus are almost overlapping. So the target did not inhibit the flankers. These are derivative maps, which basically show the spreading of the response. As can be seen, both on the left in target region of interest and on the right on the flankers region of interest. As you can see, the cortical responses started almost roughly at 90 milliseconds, lasted for 30 or 40 milliseconds before fading from the very point where it started. So there is a spreading of the response, but the fading of the response starts where the initial response started, both in the flanker region of interest and in the target region of interest. Because previous studies showed that there is a difference, that if we increase the distance of the target and the flankers, there is a different degree of inhibition, we wanted to try that with higher accuracy. So we increased, as you can see, the distance between the target and the flankers to 500 micrometers. And we recorded the temporal responses. Also in this graph, they are superimposed. And as can be seen, there is much less inhibition when the flankers are farther apart from the target. So these results confirm the feasibility and the usefulness of our setup. Then we proceeded to activate the retinal implant. So we implanted actually a subretinal device, which was 10 pixels that you can see in the image. And we proceeded to stimulate with near-infrared light, which we stimulated it with full flashes. And these are preliminary results. We stimulated with full flashes, and we can see that actually the implanted was perfectly stimulated by the near-infrared light. In B, the spatial responses, and in C, the temporal responses. What's our plans for the future? A lot of work to do. So our plans for the future are to characterize now lateral inhibition in prosthetic vision. This could have paramount implication for the future correct development, actually, and specifications of a prosthetic implant, and could help us elucidate the relationship between natural and prosthetic vision. And also, it would be extremely interesting to stimulate both the natural and prosthetic vision with different luminance. So maybe the target more stronger than the flankers stronger than the target, and in luminance, and see how vision behaves. Finally, I would love to thank my mentors, Professor Bandello, Professor Mandel, and Dr. Esposti, for the great opportunity, and all the Mandel Lab, starting from Marie, Nairuz, Tamar, and Itai, that helped me greatly to achieve these results.
Thank you very much. Roberto, you did a very interesting job, I must say. It's really interesting, with a lot of implication, and I think that in the future this could be useful for many kind of applications. One of them is for sure the use of prosthetic devices in patients with dramatic damages to their visual system. So I'd like to be connected now with Yossi. Yossi is there. We are seeing you. Yossi, do you have any comment or question that you want to address to our candidate, or please say whatever you consider useful to us?
Hi, thank you all, and I had a great opportunity to work with Lamberto. And this is, as you could see, it's a very challenging project. So Lamberto was doing a great job in making this system work. It was a kind of a teamwork, and I think that some of the results here show that we can, in the very near future, try to study the combination of natural and prosthetic vision. This is a very important issue for restoring vision in AMD patients. So I have nothing to add. I mean, this was a good work, and we are looking forward to go on with this work.
Thank you. Federico, do you want to say anything?
Thanks a lot for your work. Great presentation. So you know that the field of visual restoration is basically divided. One is retinal implants or subretinal implants, and the other one is in therapies. So, how did you develop an opinion on this? So you see, of course, in this experience, one of the two words. Can you evaluate which are the pros and cons of this kind of approach?
Yes, absolutely. Actually, in Yossimander's lab, also stem cell therapy is investigated. So I had the great chance of seeing the best of both worlds. And I think there are many pathways which can be also complementary. They don't need to be mutually exclusive. I believe that there are some advantages to the retinal prosthesis, which are, I think they are mostly in the near future are the best option in my opinion, because the studies on stem cells and on gene therapy can last many years due to obviously the gene insertion problems or mutagenicity or the long-term effect of stem cells in the body. So in the near future, prosthetic implants, in my opinion, are a feasible option, also with the rapid engineering advantages that we are seeing. Amazing. And why not? There is also a possibility to combine the two things. And in fact, Professor Mandelab also, we were trying to combine the prosthetic implants with cells, with a cell scaffold, and maybe this could be also part of the future.
Marco, our expert for retinal prosthesis. Do you have any?
Congratulations for your very, very interesting work. Planted 3 years ago here in San Raffaele a subretinal microchip. It was a very, very hard work, more than 18 hours surgery, big risk, but with a low result. And your work is very interesting to try to perform a retinal stimulation of the visual cortex activity. It's a great alternative to the surgery of microchip. Congratulations again.
Okay. Thank you. So Martin, that's fine. Thank you. Thank you so much. You need to go out. On air. On air. On air. Però questi tempi morti, cazzarola. Madonna. Molto bravo Lamberto, molto bravo, siamo tutti molto contenti. Aspettiamo che arrivino i tuoi così facciamo la dichiarazione. This is the official form. I declare that the graduate Lamberto Lafranca has fulfilled all the requirements for the master's degree with the comprehensive final grade of 110 out of 110, with honors and special mention. And by virtue of the authority vested in me by the Italian law, I confer him the master's degree in medicine and surgery and license to practice. Congratulazioni. Ok, molto bravo, complimenti.
Thank you very much, congratulations.
Facciamo una foto con la commissione, basta che ti metti qua e ti giri.
That's the way, that's the way. Grazie. Ciao, arrivederci, bocca al lupo. Complimenti. Arrivederci, complimenti. Bravo. Allora, abbiamo adesso Alessia Malerba, Maurizio Consonni.
Thank you. Good morning, Alessia. Alessia did an excellent job in our lab, together with the help of Dr. Kanji, and she had the possibility to work on a quite unique worldwide series on primary clinic lymphomas of diffuse large B-cell type, which is quite a very rare event. And we will hear from Alessia which are the major features of this particular disease. So please, Alessia.
Thank you, Professor. Okay. So good morning, everybody. And before going into the details of primary diffuse large B-cell lymphoma of the spleen and of the study we carried out, I would like to briefly introduce you some key concepts regarding diffuse large B-cell lymphoma in general. The LBCL is the most common form of non-Hodgkin lymphomas among the adult population. It accounts for about 1/3 of them, and it is characterized by an aggressive behavior. According to the WHO, this entity is recognized as a set of biologically diverse disease subtypes. And in fact, thanks to gene expression profile analysis, it is now possible to distinguish among 3 major molecular subgroups that are the germinal center B-cell-like subgroup, the activated B-cell-like one, and the unclassified one. These subgroups have different outcomes when treated with R-CHOP. It is the treatment of choice for this type of neoplasm, as the germinal center B-cell-like subgroup as compared to the others. Historically, gene expression profile analysis was performed on fresh frozen tissues by using technologies such as microarray assay, while currently they are performed on formalin-fixed paraffin-embedded material, such in the case of nanostring technology. But these latter technologies are still fully available. Moreover, all these technologies that I just mentioned are expensive, and that's why immunohistochemical algorithms are preferentially exploited in the clinical practice as surrogates of JEP findings, as they have demonstrated to have a high concordance rate with them. However, the major issue regarding these algorithms is the fact that they can only provide a dichotomic division of the LBCL, as they can only distinguish between germinal center B-cell-like phenotype and non-germinal center B-cell-like one. Moreover, according to the WHO, the LBCL is also recognized as a set of clinically diverse disease subtypes, with the LBCL not otherwise specified being the most represented entity, and which in turn comprehends primary splenic DLBCL, which therefore is still not considered as a separate entity by the latest version of the WHO classification. So primary splenic DLBCL, at a variance with systemic DLBCL, is a rare entity, accounting for less than 1% of non-Hodgkin lymphomas. Here, on the top right picture, you can see the typical appearance of this neoplasm under the microscope, while in the bottom right picture, you can see CD20 staining. It is a marker for B cells. And as this neoplasm has a B nature, you can see here that the neoplastic cells are positive for this marker. However, we only know few features regarding this neoplasm, as relatively small and monoinstitutional series are available in the literature. What we know is that splenectomy does not only have a diagnostic role, but also a therapeutic one in patients with limited stage of disease. Moreover, we also know that there is a prevalence of non-germinal center B cell-like phenotype according to the Hans immunohistochemical algorithm. It is the most widely used in clinical practice. And as you can see from this picture here, it utilizes three major markers that are CD10, BCL6, and MAM1 with a cutoff value of 30% for each of them. So on these grounds, we built our study in order to better define clinical features, treatments, and outcome of primary splenic DLBCL, to identify possible clinical prognostic markers. And we also investigated on a pilot cohort the gene expression profile of this neoplasm using nanostring technology, since the only we have come from immunohistochemistry, as we saw in the previous slide. So for the first 2 points, we selected 175 primary splenic DLBCL cases from medical centers of Europe and Israel with a diagnosis performed on splenectomy specimens and with splenomegaly as the foremost tumor site. Clinical and pathological data, as well as histopathological specimens, were available at site. Any age, stage, and treatment has been included, while HIV-infected patients were excluded from our study. We stratified our patients according to the Ann Arbor staging system, but we also introduced a novel concept, that is the concept of class of disease, because we have to consider that in general, splenic lymphomas do have a frequent involvement of the bone marrow. And as you can see from this picture on the left, once you have bone marrow involvement, you are classified as stage 4. So in line with this theory, we tried to stratify our patients in a different manner using imaging studies and histopathology with a major aim of distinguishing between patients with splenic and bone marrow involvement only from those having extramarrow, extrasplenic systemic disease. The gene expression profile analysis that we conducted on a pilot cohort of 23 patients started from formalin-fixed paraffin-embedded material from which we extracted the RNA, which was in turn hybridized with probes that bind specifically to the genes that we want to study. In particular, nanostring technology utilizes 2 types of probes that are the capture probe and the reporter probe. These are sequences of 50 oligonucleotides each that bind one adhesion to the other as they interact with the RNA, so that at the end, they span a region of about 100 oligonucleotides. The capture probe, as you can see here, has a biotin moiety at one end, while the reporter probe has a bar-coded moiety that is a combination of colors that is specific for each gene. So after hybridization, the excess probes are removed from the sample and the hybridized probes are bound to a cartridge thanks to the biotin moiety of the capture probe. An electrical field is then applied so that all the complexes are immobilized. And finally, the fluorescent microscope that is found inside the machine can then read all the material in the correct manner. In particular, for this study, we used the Link2CX assay that was firstly discovered by Scott and colleagues in 2014 for systemic DLBCL. And it is a panel of 20 genes that have demonstrated to be able to distinguish among the 3 molecular subgroups that we saw previously. So these are the clinical features we obtained from our study. In particular, I would like to highlight the median age that is 62 years, and the fact that 56% were males, and these are in line with the studies found in the literature. Moreover, the performance status was higher than 1 in 11% of the patients, while LDH level was high in 76% of them. 92% of the cases were diagnosed as de novo primary splenic DLBCL, meaning that these not deriving from the transformation of a low-grade component. We then performed several analyses in order to understand whether the different variables have an impact on the overall survival. So we started from the IP variables, where we found that age and ECOG performance status are significantly associated with the overall survival. The same applies for stage and class of disease, therefore demonstrating that this novel concept can actually provide a favorable prognostic information. We then studied the role of splenectomy, the therapeutic impact of splenectomy on the overall survival. First of all, on the whole population, where we got nearly significant findings, and then in clinical stage 1 and 2 patients, where we saw that the use of splenectomy is significantly associated with a better overall survival. We then conducted multivariate analysis, once again, first of all on the whole population, where we saw, interestingly, that age, performance status, splenectomy, classes, and rituximab are all independent predictors of the overall survival. And then in clinical stage 1 and 2, where we saw that performance status and splenectomy independently predict the overall survival, in line with Bailey and colleagues' study. Considering the gene expression profile analysis results, we can see here that there is a prevalence of non-germinal center B cell-like phenotype. However, we can conclude that we are in discordance with immunohistochemical data because the JEP analysis reveals a molecular heterogeneity that was not previously recognized at immunohistochemistry. Moreover, we can notice here that the germinal center B cell-like phenotype has dropped from 40% at immunohistochemistry to 25% at JEP analysis. And this may suggest that those cases that we identified as unclassified were part of the germinal center B cell-like subgroup at immunohistochemistry. So to recap, by including 175 primary splenic DLBCL cases, we built the largest available series so far. We introduced the novel concept of class of disease that have demonstrated to provide favorable prognostic information. We introduced for the first time the prognostic role played by age as well as rituximab. We confirmed the therapeutic role of splenectomy in stage 1 and 2 patients, but we also extended it to higher stages of disease. Interestingly, we did not find any prognostic role played by LDH. And this is in contrast with the studies conducted on systemic DLBCL, possibly suggesting that these parameters should not be considered as a universal adverse prognostic factor, but rather according to the specific lymphoma entity. And lastly, we identified a molecular heterogeneity at gene expression profile analysis that was not previously recognized at immunohistochemistry. So what about the perspectives? First of all, since we know that there are some genes that are physiologically expressed in the splenic tissue, such in the case of NOT2 and KLF2, it would be interesting to assess the mutational analysis in order to understand whether this neoplasm retains a splenic signature, as actually the other splenic lymphomas do. Secondly, it would be also interesting to revise residual splenic parenchyma or bone marrow biopsy in order to assess for the presence of a concomitant low-grade component that could be suggestive of a transformation of the latter into the LBCL. And lastly, since we conducted the gene expression profile analysis on a pilot cohort of 23 patients, of course, it would be worthy to extend it to the whole series. So before concluding, I would like to thank all the professors and doctors that helped me in performing this study. And in particular, I would like to thank Professor Ferreri, Professor Ponzoni, Dr. Kanji, Dr. Bongiovanni, and Dr. Redegalli. And thank you all for your attention.
Thank you.
The word to Dr. Kandi, who followed the
Kandi.
Yes.
Thank you. I want to just point out that the concept of nanotechnology varies this approach in research. And what are your sensations? Do you think that it can be applied in clinical? And which could be the benefit of this application?
Okay, so I think that nanostring technology is a very promising technology because it has several advantages, such as the fact that, first of all, it works on formalin-fixed paraffin embedded material that is a routinely available material. Secondly, the fact that it has a relatively short turnaround time, as it requires about 2 days for the wet part, and for the machine-related part, it also requires another 2 days, so relatively short turnaround time. And also the fact that technology has a program associated to it that performs all the statistical analysis, meaning that there's no need for statisticians in order to perform them. However, as we saw in the first slide, this technology is expensive, as it requires about 500 euros per sample, and also it is still not widely available in the different centers. So these are the two major issues regarding this technology. I think that it would be worthy to be used in the clinical practice because, as we saw during this presentation, it can provide with the molecular phenotypes of a neoplasm, and this means that you can tailor the treatment in a better manner, meaning that you can avoid the administration of treatments to those patients that do not have a good response to them.
Any other comment or question?
Yes, please. Compliments for your presentation. It has been published that the gene expression and also CNV, so copy number variation, can have an influence on the response to the rituximab. What can you say about that in your case series? Thank you.
So what we know so far is that the germinal center B cell-like ones are the ones that performs better when treated with R-CHOP, while for what concerns the activated one, they do not have a good response to it. So usually there are some therapies that are also given, even though they are not the standard, the gold standard ones, like such as the case of lenalidomide.
Yeah.
And there are not a lot of knowledge about the unclassified one.
Yes.
Because they need to be studied.
Okay, thank you very much. Thank you.
Thank you very much.
That's fine, thank you.
You should leave the room now.
Abbiamo già dato un'iniezione a una persona che era inferiore.
Bene, complimenti. Aspettiamo che arrivino i tuoi così.
Guarda che si può decidere.
I declare that the graduate Alessia Malerba has fulfilled all the requirements for the master's degree with a comprehensive final grade of 110 out of 110 with honors and special mention. And by virtue of the authority vested in me by the Italian law, I confer her the master's degree in medicine surgery and license to practice. Congratulations.
Grazie mille.
Complimenti.
Brava, brava.
Cheese.
Grazie, grazie. Sì. No. So the next candidate, Andrea Miniello. Andrea Miniello will present the thesis on secondary. Andrea Miniello, please. So the thesis is entitled Secondary Infection in COVID-19 Patients with Thrombotic Complications. Very hot topic today. The professor is Antonella Castagna and Marco Ripa. Antonella, do you want to introduce the candidate?
Yes, thanks. Andrea did a great job helping us in managing patients, collecting data, cleaning data, in order to evaluate this association between thrombotic events and secondary infection that can compromise duration of and outcome of severe COVID-19. Please, Andrea. Thank you.
Good morning to everyone. I'm here today to show you the work of Dr. Sandra about the
Andrea, you have to rise up to keep your voice, otherwise we'll never.
Okay, you're right. We don't have microphones. Okay. COVID-19 is a viral disease caused by SARS-CoV-2 for its pulmonary manifestations such as pneumonia and acute respiratory distress syndrome. However, nowadays we know that it's actually a disease which can affect almost every organ in our body. And among the most common manifestations, we have thromboembolism, which is the reason why nowadays to hospitalized patients we give prophylactic anticoagulation. In fact, as you can see here, we have in outpatients, it's very rare to detect thrombotic complications, while instead in inpatients, even more than 10% of all hospitalized patients will end up developing thrombosis. And in case of critical patients in ICU, the incidence is much higher. And the reason behind this high incidence is because there are many different components involved in the thrombosis of COVID-19. There's first of all the fact that SARS-CoV-2 uses ACE2 receptor, which is does downregulate, it does a disruption of the oral system. Then the fact that there's a strong inflammation provoked by the virus, which is the reason why we give immunomodulation to all these patients. And then other components such as neutrophils, hypoxia, endothelial damage, which all contribute to different manifestations, which are mainly venous. And the most common ones are always pulmonary events such as embolism or in situ thrombosis. Instead, about what we know about secondary infections, initially we thought that co-infections were more common, tended to give antibiotics to almost all hospitalized patients, but nowadays instead we know that the majority of are actually secondary infection, which means that they develop them in hospital setting after 1 week or more. And about this subject, our team already conducted a study which tried to characterize the secondary infection, look for their incidence, so some risk factors which we'll see later on. And behind the pathogenesis of these secondary infections, so also in this case, there are many components. Like I said, there's a strong inflammatory dysregulation caused by the virus, but also dysbiosis, not only respiratory tract, but also in the gastrointestinal tract. And then we have also to consider the role of the physician in the therapy and in the management. In fact, we give to all patients immunomodulation, which can end up making them susceptible to secondary infection. Also, we have to consider that lots of them have a prolonged hospital stay, and lots of them end up in ICU. So what we investigated in this study was whether complication could end up favoring the development of secondary infections in these patients. And then after this, we want also to characterize the secondary infection and look, for example, if the etiologies of these infections differ in patients with thrombosis. So I have to underline, first of all, that in our study, we consider only 4 types of thrombosis, which were superficial vein thrombosis, arterial thrombosis, deep vein thrombosis, and pulmonary events. And we only consider them in the case in which they were diagnosed before the infection, the diagnosis of the infection, or in alternative concomitantly within 48 hours from the diagnosis, in order to understand the complication could later on have an effect on the development of the infection. And the infection instead were diagnosed with cultural studies, but not all patients underwent cultural studies. We performed them only in the case of clinical suspicion or in the case of laboratory findings which were relevant. And then these data were combined in order to calculate the incidence rate, the cumulative incidence of secondary infection according to thrombotic complication, and then we performed lastly a multivariable analysis in order to look for the risk factors of secondary infections. This was our population, which were 904 patients of the COVID bio-B cohort during the first wave, all with positive PCR for SARS-CoV-2. And as you can see here, the median age was 64, mostly were males, mostly with more comorbidity, and 30% of them ended up in ICU and 22% died. As I said, this was during the first wave, which means that the therapy was drastically different compared to nowadays. In fact, the recovery trial, solidarity trial, REMAP-GAP, all these trial results were still not out, which means that therapies such as corticosteroids and heparin, which nowadays are a mainstay, they were not used for all patients at the time. And also remdesivir, which is now the main antiviral, instead was very little. The main therapy instead consisted in lopinavir, ritonavir, and hydroxychloroquine. And we used also immunosuppressive drugs, but only in the patients with some requisites like hyperinflammatory syndrome. This, we ended up thus with 72 patients with, in general, developed thrombotic complication, and 61 of them, the majority, developed them before the secondary infection or concomitantly. And as you can see here, the majority of them were pulmonary events, 63% of them. Instead, regarding secondary infection, 109 patients developed these infections, and as you can see, the majority of them were bloodstream infections, which were mostly caused by gram-positives. While in case of respiratory isolates, they were mostly by gram-negatives, but 1/3 of them were also caused by aspergillosis. Then we combined this data in order to look for the incidence of infection according to thrombosis. And as you can see here in the first graph, we found a significant difference in their cumulative incidence. In fact, in the first week, both of the groups tend to not develop infections because usually secondary infections take 1 week, 10 days in COVID-19 patients in order to develop. But after the second week, you can see that the patient with thrombotic complication start to develop a secondary infection at a higher rate compared to the other group. And the same can be observed also in bloodstream infections. But the same cannot be said instead for respiratory infection, in which instead the difference was not significant. Then we perform our multivariable analysis in order to look for risk factors. And we found 2 risk factors, one for the development of secondary infections. One is ICU admission in the first 48 hours, which was a result already found in the study by the same group which I showed you before. While instead, as a new finding, we found out that, yes, thrombotic complications are indeed an independent risk factor for development of a secondary infection, and thus our primary objective was confirmed. Instead, regarding the secondary objective, We looked for the difference in etiology between the two groups with thrombosis and without thrombosis, but in the end, the difference was not significant. So the etiology was the same. Our study, of course, has some limitations, such as the fact that it's a single-center study, so it's not generalizable as a result. We did not have data for all patients regarding use of antibiotics and intravascular catheters. And also we have to consider that we did not perform cultures or imaging for thrombosis in all patients, so some cases could have been missed. And lastly, for multivariable analysis, we did not have data for all patients, but only 600 of them compared to the 900 in total. But in conclusion, we can say that in our case, the patient hospitalized with COVID-19 and affected by thrombotic complications ended up being at higher risk of developing secondary infection. But the secondary infections did not differ etiologically instead. About this study, we call them some interesting future uses. For example, if thrombosis are indeed an independent risk factor for developing secondary infection, we could use them, for example, as a predictive tool, which means that if a patient develop thrombosis, we could start looking from the laboratoristic point of view more closely to it in order to monitor it and look for a secondary infection as soon as possible. But also it can be useful in general to diagnose bacterial infections in this patient, because in COVID-19 patients, the diagnosis, symptomatology, and the laboratoristic finding can sometimes mask the presence of a bacterial infection, and thus it's not always so clear. And lastly, there were this trial, which was conducted by ATTAC, T4, and REMAP-CAP about anticoagulation. Those results were published very recently. We suggested that instead of using prophylactic dosage of anticoagulation in non-critically ill patients, we could use a therapeutic dosage, full therapeutic dosage, because they saw that in these patients, in this population, the survival improved. And one of the possible suggestions behind this improving survival could maybe be the fact that a decrease in thrombotic complications could maybe lead also to a decrease in secondary infectious events. However, secondary infections were not among the secondary outcomes of this study, so we can only speculate, and further studies are needed. I want lastly to thank Dr. Castagna, Dr. Marco Ripa, Dr. Laura Galli, and Andrea Polli, who all assisted me in this dissertation, were involved in the study. All the people I had the pleasure to work with Turo during this year. And lastly, more importantly, all the researchers of COVID Bio-B study group who made this study possible, and also all of the people involved in the fight against the COVID-19. Thank you for your attention.
Thank you. Thank you.
We are a little bit late. I leave Marco.
Okay, so thank you for your presentation and thank you for your hard work. And I would like to stress out that this work has already been accepted as an oral publication in Congress, so it's even more interesting because it's not public. So thank you for your hard work. And I was wondering, your last slide, you hypothesized that maybe we can try to decrease the risk of thrombotic complications in order to also decrease the risk of secondary infections. Do you believe that we may have other therapeutic tools in order to reduce the risk of thrombotic complication and to reduce the risk of the overall inflammation in these patients, maybe also reducing the risk of secondary infection? So is there something else besides antithrombotics or therapeutic anticoagulation that you think we can use?
Well, actually, there was a study also made in this institution about the possible rationale regarding the use of antiplatelets in COVID-19 patients, because actually platelets are directly activated by SARS-CoV-2 in a direct way And it has been hypothesized that behind the immune dysregulation, a platelet can also have an important role to secretion of cytokines and also to binding directly of neutrophils, which means that basically they prevent the activation of neutrophils. But unfortunately, in the end, they did not. I did not find studies regarding the use of antiplatelets in COVID-19 patients which had any kind of clinical benefits. So instead, most of the studies are regarding heparin. Heparin because heparin has a good role as an anticoagulant, but also to have some effects regarding some anti-inflammatory properties of this molecule and also even some antiviral properties. So could end up lastly having different effect of this kind of therapy, which can end up with improving survival and also in reduction of infections.
Thank you. Other questions? Professor Mortini?
No question.
Thank you. Thank you.
Thank
That's
you.
done. Appare un po' rapida, ma
sì.
insomma da qualche parte bisogna risparmiare. Che pezzo di gnocco, porco di un cane. Quello è un pezzo di gnocco che se voi lo date fate in giro. Fallo vedere alle donne, fallo vedere alle donne se coraggio. Fallo vedere alle donne se coraggio.
Che roba abbiamo lì,
Giovane. Giovane.
Quello col cappello?
Sì.
Quello col cappello?
Giovane, giovane.
Ragazzi, stai finendo anche tu. Stai finito anche tu, dai. Finito. So, I declare that the graduate Andrea Miniello has fulfilled all the requirements of master's degree with the comprehensive final grade of 110 out of 110 with honors. And by virtue of the authority vested in me by the Italian law, I confer him the master's degree in medicine and surgery and license to practice. Congratulations. Fai la foto. Grazie.
Thank you.
So the next one is Gianluca Nuzzo. Where are you from, Gianluca? Caserta. And infatti, he will present a thesis entitled Gamma Knife Treatment in Brain Stem Systematic Review with Professor Pietro Mortini and Lina Raffaella Alessandra Barzaghi. Professor Mortini, if you want to introduce.
Yes, just a very, very short introduction. Gamma surgery is becoming one of the most interesting technologies in the treatment of brain tumors. However, the data available on the treatment of cavernomas are very limited. So the candidate decided to analyze those data into the literature and to update this committee on this topic. So would you show the results of your research, please?
Sure. So before starting, I want to thank Professor Martini and Dr. Barzaghi for the introduction and for giving me this opportunity. Today I'll present you, as I said, a gamma knife systematic review about gamma knife treatment in brainstem. A gamma knife treatment in brainstem lymphomas, which is a systematic review. These lesions are also called as cavernomas and are part of non-neoplastic vascular malformation of the CNS. They have been classified by McCormick in 1966 in this classification, which divided the non-neoplastic vascular malformations in arteriovenous malformation, capillary telangiectasia, venous angiomas, and, as I said, cavernous malformations. These lesions are also called Mulberry lesions because of their appearance both in MRI and macroscopically, as we can see, because of their shape and color. They can range from few millimeters to more than 10 centimeters and more. And at histologic evaluation, we can find a thin endothelium which lacks a muscular layer. And also differential diagnosis can be done histologically because nervous parenchyma is absent in the interstitium in the cavernous malformation instead of, for example, capillary telangiectasia. At the state of art, the gold standard for this pathology is macrosurgery, even though sometimes the location of the disorder can cause some problems in that we do not have an available surgical corridor, especially in brainstem cavernous malformations, which are comprehend 9 to 35% of all cavernomas, and being located in eloquent areas, sometimes, as I said, it's hard to find certain surgical corridors. The main studies that were done to analyze, let's say, the epidemiology of these disorders were done through the analysis of more than 22,000 MRI images and postmortem studies. And this has shown this distribution that you can see, so a 62%, 40% in midbrain, 5% in medulla, and 12% each in the pontomesencephalic and pontomedullary junction. The clinical presentation of cavernomas can be very various. It's obvious that seizures are not present in brainstem cavernomas, opposite to the supratentorial counterpart. But in this area, since we have essential fibers that pass by, hemisensory loss and mainly cranial nerve deficits are the main that we can see in the patient. The main issue with these lesions is hemorrhage, intracranial hemorrhage, especially in the brainstem one, since being in such an enclosed space and narrow space causes every single hemorrhage to be almost always symptomatic and also many times life-threatening. The natural course of the disease is that it's highly heterogeneous because we do not have a linear let's say, development of the disorders in terms of bleeding. We're bleeding and reshaping. So we can have also conservative treatment, the difference in volume, like by time and time. Imaging can be divided, let's say, in pre and post MRI era. This because before MRI, so around 80s, let's say, these diseases could be found just through CT, even though the sensitivity was not so high because just the cavernomas which had calcification inside them, so around 50% could be found. And because of this, these lesions were also called occult, geographically occult. Then, after the introduction of MRI and available, we started to be able to have higher certainty in the diagnosis of disorder. Here you can see the Zabransky scale, which unfortunately is not used in clinical practice, but this correlates the MRI findings with a possible pathology that the patient may have, and basically divides cavernomas in 4 types. just looking at the kind of hemorrhage that is present. And is DTI, which is used in MRI, and it's able to give us information about the functional fibers of the that pass by the bracing to organize the treatment in a better way and avoid complications and avoid touching maybe some fibers, some healthy fibers. Regarding the management, as you can see, first of all, we have the discovery of the cavernous malformation. We have to check whether it's tinted or not. In case there's no clinical presentation, of course, we have an incidental cavernous malformation, and in this case, we can just follow a conservative management and just an yearly MRI to follow the patient. While in case there was a severe clinical presentation with an hemorrhage and then some disorders, we have to check, looking at the patient's characteristics, whether or microsurgical resection is the best. Usually we check this by checking the location of the lesion, if it's close to the PL surface, for example, or if it can exceed the location. So the main question I'm trying to answer is why gamma knife should be used in bracing cavernous malformation. First of all, because there is a similarity between bracing cavernous malformations and arteriovenous malformation, and it's well known the effect of gamma knife on arteriovenous malformation. Second of all, there are certain situations, as I already said, for example, the exceeded cavernous malformation in the bracing, which do not have an available surgical corridor, and so the surgical risk is unacceptably high, and we cannot proceed with the surgery. And finally, because gamma knife is well known also in reducing the bleeding rates of the various vascular pathologies. Rebleeding, in fact, is the most important factor in this disease. It is referred to as the annual hemorrhage risk, and as you may hypothesize, there are certain factors which increase the risk of in these patients, such as the female sex or multiple lesion in case of a familiar cavernous malformation, or association with the developmental venous anomaly genotype, which is the CCM3, or also diagnosis before 35 years old. But the most important risk factor for hemorrhage is a previous hemorrhage. This can be explained by looking at the electronic microscope, which allows us to see that in the cavernomas which bleed more, there are less and less functional tight junctions. This may be one of the goals for the extravasation of red blood cells. And as you can see from the picture, like it's related, the number of bleeding is related to the annual hemorrhage risk. So in case a patient did have no prior bleedings, he has around 2 to 7% of risk of hemorrhage, while if he had one prior bleeding, he had around 20 to 30%, and 2 or more prior bleedings was a 60% annual hemorrhage risk. Back to the schematic review. Here you can see the steps that I used to choose the patients to evaluate. In the end, a total of 164 patients was chosen, taken from 3 studies. And the main aim of this study is to elucidate the topic, describe and determine whether stereotactic radiosurgery is actually an efficient and safe methodology. These are the results of the 3 studies, results taken. The main data that you can see here are the pre-GKS AHR and the post-gamma knife surgery AHR. These are the results of the review. First of all, epidemiologically, we can see that there is a slight female predominance, and the age of onset of diagnosis is 40 years old, more or less. The mean target volume studied was around 0.92 centimeters cubed. And as you can see, the pre-GKS annual hemorrhage rate was 32.1%. Soon after the stereotactic radiosurgery went down to 3.79. 2 years post radiosurgery, 1% roughly, and 5 years post to 1.5%. even though this last data here, it's just kind of fashion because out of the 3 studies, just one had a follow-up of more than 2 years or 5 years. The margin dose that was used in order to avoid having adverse reaction effect was 13.6 gray. And while regarding the volume of the lesion, it wouldn't be possible to say whether there's a decrease or increase in the volume because, as I said, the natural course of the lesion is not so linear, so we do not know whether the supposed to or not. And out of the 164 patients, just 11 suffered adverse reaction effects. And out of these 11, 2 of them developed de novo cavernoma formation, which is kind of a patient because both of these patients, when were treated, had the exclusion from the treatment of the associated DVA. So this suggests a kind of correlation between the developmental venous anomaly and the formation of a cavernoma. It's not quite clear, again, why the risk of hemorrhage is reduced after radiosurgery. One hypothesis is that there is endothelial line channels undergo progressive healing into the thickening of the vessels and eventually luminal closure. This can be also due to the pathologic radiation-induced vasculopathy due to the gamma knife. Regarding instead adverse reaction effects, since 1992, we started using lower doses of gamma knife, and since this reduction in doses, the ARE started to be much less common. In particular, there's shown a correlation between adverse reaction effect and hemosiderin, which is found around the hemorrhages of the cavernomas, since this hemosiderin ring has a radiosensitization effect, and so a magnification of the gray used. Other side effects, for example, loss of balance, numbness, headache, edema, can be instead, let's say, cured with medication soon after the treatment. One last radiosurgery is the latency period, since it has been shown that to have an actual effect, stable effect, a knife, we need to have a minimum of 15 to 24 months of wait after the surgery, the stereotactic radiosurgery, in order to have the effect to be stable. Lastly, I want to conclude with the clinical, which is very informative and interesting, in my opinion. Is a 20-year-old female which had 2 bleedings in the past 12 months. The first bleeding, she had diplopia and headache lasting 2 days. In the second bleeding, diplopia lasting 1 month. And at MRI, the diagnosis was subthalamic cavernous malformations. These are coronal T2 and axial T1 post-contrast MRI images, which can allow us to see the cavernoma in the subthalamic area. As I mentioned earlier, in MRI, we have the use of PTI, which is being of great help in this element. Because as you can see, fibers can be reconstructed so that in this particular case, for example, the white fibers, which are the somatosensory fibers, and the red fibers, which is the subthalamic nuclei, are not injured during the procedure. And so we do not have side effects in this case. 3 months after gamma knife radiosurgery, the patient had direct bleeding with diplopia. And here you can see hyper intensity here around the cavernoma, also with a halo of hemosiderin. And at 30 months after gamma knife radiosurgery, so after the latency period has passed, no new bleeding was shown, cavernous malformation volume decreased, no neurological defects were shown. And these are the images again of a T2 and a T1 post contrast, in which we can see kind of obliteration of the cavernoma with just the hemosiderin halo all around it, without increase in the volume. Again, I would like to thank Professor Martini and Dr. Barzaghi, and thank you for your attention.
Thank you.
In radio surgery, the definition of the target is very important because we use a single fraction and high dose. So the distinction between brain normal tissue and pathological tissue is very important. It must be very accurate. Reviewing the literature, can you obtain some evidence-based indication about the definition of the target, the role of abnormal venous drainage? Do you include or not the target?
Okay, let's say that first of all, developmental venous be seen in many of these cavernomas. In the majority of them, there has been shown a kind of consequential steps, let's say, that brought from developmental venous anomaly to become an actual cavernous malformation by first the increasing pressure inside the malformation, then there is the efferent vein blockage and the extravasation of blood, and then there is the cavernous malformation. This to check, let's say, the actual presence of this. First of all, we can, among all the different sequences that we could use, I would suggest that T2, even though there are other sequences such as the susceptibility weighted image or gradient ego, which are much more, let's say, informative in many situations when we are on a borderline. In case of developmental, it again depends on the, as with cavernoma, on the location of the anomaly and really on the fibers that go adjacent to that area that are that area that cannot be injured, or that in other cases can be DD. So those, let's say, can be adjusted not to damage the area.
Okay.
Thank you.
Thank you. Any other question? No. Thank you so much. Thank
Do I
you.
post this, or
Pardon?
do I post the PowerPoint?
Don't worry. So.
Un po' di coerenza.
Dobbiamo veramente accelerare, eh? Questo Pietro non sembrava tuo, sembrava uno mio.
Purtroppo tutte le ciambelle credo che sia in assoluto dai miei e quello che ho il partito più tardi. Poi ho fatto una tesi ispirativa.
No, mica 17 sono altri problemi.
No, io dico.
No, non diceva che mica tutti hanno.
Me ne ricorderò.
Adesso lo facciamo entrare o no?
Sì, è andato a vestirsi.
Ho capito.
Via 2 volte. Via 2 volte.
Oh, cappella.
Voglio mostrare la mia. I declare that the graduate Gianluca Nuccio has fulfilled all the requirements for the master's degree with the comprehensive final grade of 110 out of 110, or 102, sorry, 102 of 110, and by virtue of the authority vested in I confer him the master's degree in medicine and surgery and license to practice. Thank you. That's for you. That's un regalo. Complimenti.
Ma non venderle,
Ciao, arrivederci, tanti auguri. Ciao. Grazie. Grazie. So the next candidate is Mr. Mario Pezzella. He will present the thesis entitled Effects of Chocolate Intake on Retinal Vessels Morphology and Functionality. And Giuseppe Querques will introduce the candidate. And please, Giuseppe.
I can simply say that Mario was like a Mastino since your Napoli origins, because he was really effective in finding subjects for this very interesting study that he will be showing us in a while. And I'm really proud of him, the way the study worked, and I hope you will enjoy it.
Importante il cioccolato. È importante.
Good morning, everybody. Thank you, Professor Querques, for the kind introduction. And I'm honored to be here to expose the thesis we carried out in Ospedale San Raffaele in the ophthalmology department, entitled Effect of Chocolate Intake on Retinal Vessel Morphology and Functionality. First of all, I will start giving you a general idea on the systemic effect of dark chocolate. In particular, dark chocolate contains high quantity of flavonoids, which can activate the NO-cyclic-GMP pathways. Effect in different parts of the body, in particular in the cardiovascular system, it will lead to a vasodilatory effect, again giving rise to a decrease in blood pressure and a sudden increase in flow-mediated dilation. Also, an increase in coronary flow reserve is seen in this patient after a consumption of flavonoid-rich dark chocolate. It was also seen that in patients at risk for cardiovascular disease, the consumption of dark chocolate was increase in nitrosalate species, and again an increase in flow-mediated dilation. Some sort of effect also at the level of the brain were found in literature, in particular an increase in cerebral blood flow and an increase in the expression of some neuroprotective factors that again are leading to an increase in neurosurveillance in the region of the brain adapted to learning and memory. But today we're gonna concentrate ourselves mostly on the eyes, because all the previous studies were, in majority of the cases, inconclusive and having mixed results. In fact, one of the latest research in this on this matter was conducted by Sidecki et al. In 2019, was published in, and it shows that apparently flavonoid dark chocolate has no short-term effect on the retinal blood flow. But the point with this study is the fact that basically they only did a static type of analysis following the optical coherent tomography angiography. This is why we wanted to add something more. We wanted to study dynamically in vivo what happened. And we found that in literature there were no studies that were using a type of machinery, the DVA, dynamic vessel analysis, to study the functionality of the vessel from another point of view. So we designed our study to be randomized, masked, a crossover, and thus we decided to investigate dark chocolate versus the milk chocolate intake in young healthy subjects. How we did it? Basically, the classical assessment of BCVA, the latest slit lamp anterior segment analysis and fundus by microscopy, the optical coherent tomography, the OCTA, and then we added this. To evaluate the retinal vascular functionality, we decided to add the dynamic vessel analyzer. For evaluation of retinal vessel diameter, we used the hardware. That's how we basically designed our study, which was approved by our EC. And basically, we had participants, all eligible because all met our inclusion criteria. And then all 20 of them were randomized into arms. The first arm were allocated to receive first dark chocolate, and 1 week later to receive milk chocolate. every of this visit was divided into parts. The first part was the baseline, in which we performed all the previous assessment. Plus, at the end of the baseline, we gave the subject 20 milligrams of dark chocolate. And 2 hours after the intake of chocolate, they were coming again to conclude the visit, to perform again all the same examination. The same happened in the second arm. The only difference is the fact that we have a cross study. So in the second arm, they first received the dark chocolate at the first visit, while at the second visit, they received dark chocolate. Here I show you briefly the demographics to show you that all the patients were basically healthy and young in particular, because the mean age was 24. Now I would start with the real important imaging we performed. First of all, the OCTA analysis. As you can see in the first row here, we have a 6x6 image took directly from this machinery. And what we did was basically, first of all, there is a second row below. You can find different colors, in particular the blue one. The blue one in the second line indicates the FADS, which is the fovea vascular zone. Basically, we manually delined it because we didn't want to compute in our calculation that particular area. But starting from the image on top, in particular the superior capillary plexus and the deep capillary plexus, also the capillaris, was binarized using a particular to convert the image from 8-bit to RGB, red, green, blue color. And what was seen in the image below is the fact that apart from the blue color, we have white dots, white pixels, which represents each of them a vessels, while the black pixels represent this was all done to perform and to study the perfusion dilation at the level of these different areas. And now I show you the results we gained with our OCTA analysis. The results, as you can appreciate, were not significant, or at least they were confirming the previous studies. So at this point, we said, okay, it's very similar to the other one. Thus, this is why we decided to add some other imaging evaluation, which is, as I said before, the DVA and the RVA. Now, they studied, as I said, and they work in a different manner compared to the OCT. Basically, in particular, the DVA is using a green light, which is emitted by the instrument, by the machinery, with a wavelength of 530 to 600 nanometers. And the way the vessels and the surrounding tissues respond to this light is reflected back to our machinery, and it's possible to compute the percentage of dilation of the arteries, also their diameters. The same happens for the vein, of course. The RVA, instead, the retinal vessel analyzer, is again, it allows us to understand the functionality of the veins and arteries in time. And it uses another type of light. In particular, this one is a wavelength from 400 to 620 nanometers. And basically, again, it was both of them were used to understand some, let's say, of the retinal vessel. And now I show you the results we found out. And in particular, I want to point out that we found the significance at the level of the arterial dilation using this functional and dynamic analysis. So we came to sort of conclusion that dark chocolate can favor in some way arterial dilation. But we asked ourselves why this happened. So we went back basically to physiology. As I said at the beginning of the presentation, dark chocolate contains very high level of flavonoids, in particular when it is pure cocoa. And they have the ability to trigger NO synthase, nitric oxide synthase, which, as the name suggests, is leading to an overproduction of NO. And NO will trigger at the level of the muscular smooth muscle cells, the soluble guanylate cyclase, which again will increase a lot the concentration of cyclic GMP, ultimately leading to relaxation, thus to vasodilation. This is why the conclusion on our study were, first of all, confirming that performed with the CTA, there was basically apparently no short-term effect of dark chocolate. Using the way, instead, we observed a significant greater dilation response of the arteries, thanks to the flicker light analysis. But also, what was important is the fact that the way allows to have a direct vessel response, to appreciate this vessel response in vivo, while maybe further studies are doing it, all the other studies were doing it in vitro. Thus, at the end, I would say the further studies at this point are needed in order to understand if really this retinal vessel deletion could play favorable role in the clinical course of vascular retinal diseases. Thank you for your attention. In particular, I'd like to thank all the Department of Ophthalmology for supporting me, helping me throughout this study. Thank you.
Thank you. Thank you. Giuseppe, Riccardo, do you want to make any comment? Riccardo, do you want to start?
Yes. Congratulations for your work with the field. I would like to ask you your personal opinion about the application and the of results about the application of the organs and system of our body. We know that on one hand, we represent the windows of our body because we can visualize directly with the vessels. But on the other hand, retinal situation starts the lines and here features the presence of the pathogen.
Well, I think that maybe the reproducibility of this study, I would say, would be more positive is repeated in some sort of immunoprivileged sites similar to the blood retinal barrier. So, for example, also the blood-brain barrier, which has an anatomy and a functionality very similar, also somewhat at the level of the testis in some way, which is again has a similar composition to what is the particular vascularization of the retina vessel in the forehead. So maybe in that area, the reproducibility is more positive. I think that in other general part of the body. That's my honest opinion.
Professor Quentas.
Yes, again, congratulations for such a beautiful work. Congratulations because you did all alone, completely all alone. So what you are seeing is what the candidate did completely alone. Find 20 subjects. It was so convincing in a very short time. So really impressive. So congratulations for that. And the results are impressive because for the first time we demonstrate dynamic effects on retinal arteries that may mimic a kind of surrogate of what happens in the full body, so on a systemic point of view. And this is really important not only for retinal diseases, retinal vascular disease, but also for systemic condition. But can you just clarify more in deep how did you decide to check in terms of timeline and also the quantity of flavonoids and let's say of dark chocolate to administer to
yes, of course. Well, for matter of time, I didn't stress you with all how we decided the particular quantity and why we decide 2 hours later, but it is all seen basically in literature because what we saw is that some biochemical studies demonstrated that there is a peak of flavonoids, so which are contained in dark chocolate, at 2-3 hours after ingestion. This is why we decided for wait 2 hours after the ingestion, also because we need to perform a lot of examination, so maybe also something like 2 hours and 15 before we administering all the other. Instead, for the quantity, which was 20 grams, we decided to provide it because other studies were said that in some young and healthy patient, the good quantity to see some results, also at systemic level, was from 20 grams. So we decided to check to use the minimum concentration because while in other study maybe the patient were a little bit more aged, I would say like 30 to 40 years of age or 40 to 50. Our patients were like 24 as a mean, so we use the lowest quantity possible because of this reason.
Okay. We have no other question?
Swiss chocolate.
Swiss chocolate, 90%.
Okay, thank you, thank you. Dove è finito? Ma dove l'avete lasciato?
Eccolo.
Eccolo, arriva.
Allora, ci siamo. I declare that the graduate Mario Pezzella has fulfilled all the requirements for the master's degree with the comprehensive final grade of 104 out of 110, and by virtue of the authority vested in me by the Italian law, I confer him the master's degree in medicine surgery and license to practice. Congratulations.
Una foto con
Grazie.
Bravo Marione, bravo ai genitori e non. Complimenti.
Grazie. Grazie, arrivederci.
So, the candidate is Zainab Raouf. Is that correct? Perfect. She will present a thesis together with Professor Secchi and Dr. Faccincani entitled Development of a Natural Language Processing-Based Prediction Model for Clinical Deterioration of COVID-19 Patients in the Emergency Department.
Okay, thank you, Professor Bandello. Zainab, ready? Okay. In clinical medicine, prognosis is an important factor to a fair allocation of resources, being by definition in a limited resourcing setting. And this is very important period of pandemic, and the prognostic tools must be rapidly available just to avoid waste of time. And the thesis of Zainab is focused on that with a new tool that will be help in a rapid definition of which patient should be treated in the highest way than the other. Please, Zainab.
Okay, good morning, everybody. This is my thesis, and it's about the development of a natural language processing-based prediction model for the clinical deterioration of COVID-19 patients in the department. Under the supervision of Professor Secchi and co-supervisors Dr. Roberto Faccincani and Dr. Silvio Franchini. So, as we all know, the COVID-19 pandemic is a global health crisis that was precipitated by the severe acute respiratory syndrome coronavirus 2. And as of 10 minutes ago, there have been up to 175 million cases confirmed and 3.8 million deaths of those that have been documented. This is culprit of a very devastating respiratory disease, and it has ultimately triggered a mass demand in limited resources. So what is the idea behind this study? It is to facilitate the clinical management of COVID-19 patients in order to appropriately allocate diagnostic and therapeutic resources. So the aim is to develop a prediction model that aids in identifying COVID-19 patients for those that are of high risk of clinical deterioration in the emergency. So what is artificial intelligence? Artificial intelligence is a term that was first described by John McCarthy in 1956. It is defined as the science and engineering of making intelligent machines. It's a broad term used to describe the extensive spectrum of technology that's aimed in mimicking the cognitive function of human behavior. Machine learning is a subset of artificial intelligence, and it is practically an application of mathematics and computer science. This is accomplished by defining a model for complex interpretations that allows an algorithm to extrapolate information. Deep learning is also known as deep neural network, and this is a subset of machine learning, where machine learning is a subset of artificial intelligence. And it's a special type of machine learning where it's inspired by the functionality of our own brain cells. It simply takes data that is it creates artificial connections and artificial neurons, and it's capable of learning from data unsupervised. So natural language processing is a very broad umbrella term that is used to describe the process of utilizing these computer algorithms in order to identify key elements in everyday language and extract valuable meaning from unstructured written input. Well, what is unstructured written input? So we have structured and unstructured data. The structured data is a quantitative data which is present in the form of values. And an example of this lies in the vital parameters, in the laboratory examinations, the ICU date of admission. And then we have unstructured data, which is qualitative data. And for this, there is no predefined format or organization. It's present in the form of a text file, so it's a very scattered document. And the examples that lie within unstructured data are regarding triage documentation, medical history, the clinical diary, any form of consultations by another specialist. So this study is a multicentric retrospective cohort involving Humanitas Research Hospital and San Raffaele Hospital. The patients were extracted from the 20th of February 2020 to the 31st of May, which is the estimated duration of the first wave. So we enrolled a total of 1,296 patients. The inclusion criteria was based on positive microbiological evidence of the SARS-CoV-2, based on positive analyses from bronchotracheal aspirate, bronchoalveolar lavage, or nasal or nasopharyngeal swabbing. The exclusion criteria included patients that were self-discharged, left the hospital on their own terms, if a patient was exported to another external hospital or facility, or if they were directly admitted to the ICU. So the data, once gathered, went through some processing steps, and they were extracted from the electronic medical records. So the data processing went through a pipeline, which involved anonymizing the data to remove any sensitive information, preparing the data, which included eliminating any missing or incomplete values, eliminating the duplicate ones, and then pre-processing, which involved getting rid of the outliers and some laboratory values that were insignificant, for instance, a low D-dimer level. And then once the databases have been, once they're identical between Humanitas Hospital and San Raffaele, they were merged into one file. They could be set for the model, the prediction model. So here, of the data that we collected, we have the population characteristics between the two cohorts. So we have Instituto Clínico Humanitas and OSR, and we gathered 509 patients from Humanitas and 787 patients from San Raffaele. Of the notable characteristics that we can see, similarities between the two databases collected, we can see that there was a high prevalence in the male population. Additionally, the symptom durations lasted up to 7 days. Fever was present in up to 80%, 80 to 85%, from 50 to 57, and dyspnea, shortness of breath, for 45 to 50%. Of the comorbidities that were common between the two cohorts, diabetes and cardiovascular disease. And then radiological evidence that was suggestive of COVID-19 ranged from like a staggering to 79%. And then we have the outcomes, which is what we will be focusing on as the target for this study, where the death and the ICU admission have similar values between the two cohorts. This is a tabular model, so we took numerical values and not. So this is the structured data that we assessed. This we can establish as a control to compare it with a model that looks at both structured and unstructured data. So here we are looking at data. We use the Matthews correlation coefficient in the F1 score to measure the accuracy on the data set. So the precision is the positive predictive value, and the recall is the sensitivity. So we use the F1 score because it is derived from the weighted average of the precision and recall. And here we can see the F1 score for the outcome of 30-day mortality for this predictive model based on numerical variables alone was 62%. And we can appreciate an area under the curve in this rough curve here of 0.84. Now looking at the other outcome, ICU admission, we are looking at the same structured data here, and we can appreciate a F-score of 60.2% and an area under the curve of 0.83. So when predicting the predefined outcomes for COVID-19 associated 30-day mortality or ICU, the calibration of the algorithms had to be through a reliability diagram. So the predictions model, the accuracy was plotted against each other. So the red dotted lines here is the ideal calibration of the algorithm. The blue columns are the actual predictions that were performed, and then the red is the gap between our algorithm prediction and the ideal prediction. So here is the model where we are looking at both structured and unstructured data. So we can see here that we were free text data that is analyzing the triage description from when patients are admitted to the emergency department. And here we can see that we've achieved an F score of 81.6% for 30-day mortality. So the results, when we compare the tabular versus the tabular, there was a very high predictive accuracy with an F1 score of 81.6% in comparison to the control model that was based on tabular data alone, that was 68.1%. So we can see that these results showed that the addition of this algorithm, this natural language processing, does play a significant role in the accuracy of the model. So by means of this, of being able to read the unstructured data, it could play a fundamental role in analyzing electronic medical records by this artificial intelligence algorithm. And this is critical if you want to identify the patients that are most severe so that we may allocate them the most appropriate resources. With the unprecedented amount of data that is available in combination with all the advances, the power of this tool is unparalleled. So it has the potential to become very cutting-edge technology in both the diagnostic and the prognostic aspect of clinical disease. We encountered a lot of limitations. The pandemic was one for starters, causing a lot of stress on physicians. The retrospective aspect of the study was that we could not establish a set of rules for physicians to follow so that we may accurately collect information. Grammatical errors are also a concern because as this is a computer reading text, it cannot identify a word if it is incorrectly spelled. And again, incorrect clinical documentation, also in line with the pandemic, because during this very stressful period, physicians do not have time to grammar check, take the time to correct a clinical diary while a patient is physically in signs of respiratory distress. And another two very big limitations that we encountered that did affect the study is the excessive power consumption and the long processing times. And I explain this because I do not currently have the text and tabular data for the ICU outcome. And this was because the machine and the data was so excessive that, like any system in computer, it ended up crashing. The conclusions. We were able to develop a prediction model for the clinical deterioration of COVID-19 patients that were admitted to the ED based on both this structured and unstructured data. And the use of such a tool for any physician, whether it be in the ED, ICU, or any other clinician, is essentially paramount because it can justify a very timely and accurate response and course of action regarding the appropriate therapy of a critical patient. Should this be applied anywhere, this can be applied to any patient, not necessarily critical. So we have a few areas of future perspective, and we would like to possibly employ external cohorts so that we may reduce the generalization. A prospective study so that we can establish a set of rules to better collect the data. Obviously, a larger sample size would be of great advantage. The recruitment of more hospitals. Real-time use. It would be very nice to see the actual application of this model used in other fields apart from the emergency department. So that is it, and I would like to thank you all.
Thank you.
Thank you very much. Thank you, Zainab. Dr. Faccicani, please.
Thank you very much. So you have done a very great job, first of all, because you've done almost it all alone. I mean, even the research group, because it involves a lot of people, is a bit far from the results that you are presenting here. So you have elaborated them a lot on your own. So excellent. And then, I mean, what is really incredible is how you mixed two of the most hot topic of the moment, that are the COVID-19 outbreak and the machine learning. So I'm really interested. You have a chapter in your thesis work regarding the literature application of machine learning in medicine. How you, just to tell the commission how huge is the perspective of this application?
Well, machine learning, I found while reading through medical literature, was very, very specific in the field of radiology. And all of these algorithms do not use a natural language processing. They are based on other techniques outside the degree of medicine that is very good for, okay, for instance, if we are able to create an algorithm that can potentially identify the differences between a bacterial and viral pneumonia, that would change the entire course of action of the patient. So this is considering, but if we were able to employ this into other fields, for instance, if we were to employ it in the field of pathology, if we were to employ it in the field of cardiology, it could be paramount in being able to identify the things that we would not be capable of identifying ourselves.
Good. Thank you. Any comments?
Other comments?
No.
No, agree
Okay.
with this one.
No, yes, please.
Thank you for the presentation, for this very interesting, very beautiful method. And I was just wondering, I mean, what it appears from your study is that the addition of unstructured data, which is something which is not already data, is something intuition or the first opinion of the patient adds very much to the predictive value of your study. So I was wondering, how do you, I mean, do you think that this may be also useful in limiting the use of some diagnostic tests? So when you have the clinical judgment that adds something to the diagnostic test, maybe we can try on unnecessary diagnostic tests when the clinical judgment is better than other diagnostic tests. So do you think that this may be also useful in limiting the use of unnecessary laboratory tests or imaging studies or other procedures like that?
I do agree. I actually very strongly agree. And if I can think of an example, perhaps in the emergency department, if a patient is presenting with a headache, let's say for instance, and the patient is young, and you don't want to expose radiation, perhaps you can use the algorithm to look in the medical records to see if there's any existing comorbidity that existed, any medications that this patient could have taken, anything that could be indicative of any sort of pathology that might necessitate, which you would essentially want to avoid in the young patient. So I'm pretty sure there are many more cases where that could be applied, but I do agree, yes.
Thank you.
Thank you.
One more comment from me. One of the critical points in in applying the machine learning is the model, is the critical choice of numerical variables.
Yes.
How did you choose these variables in constructing the setting? Because I mean, this is really
Critical point.
critical
Yes.
point, yeah.
So as this was a retrospective study, unfortunately, we had a lot of time, given the unfortunate circumstances of the pandemic. There was a lot of medical literature actually already collected. So we analyzed previous studies that indicated values that were suggestive of poor prognosis, which was why we analyzed C-reactive protein, hemoglobin, the liver enzymes, because it was stated and already studied in literature. So
what about lymphopenia?
We did consider that value, but in the prognostic model that was given to me, it was not analyzed.
Thanks.
Thank you.
Thank you.
Brava.
Thank you. Okay, thank you.
Emily, siamo piacere.
Sì.
Stanno arrivando? Va bene.
Pare che non mi interessi.
Ok.
Ah, sono di là, fateli entrare.
Poverini, dai. Da dove no, sono pronti per
Irlanda. Irlanda.
They will celebrate.
Dove
siete? A Dublino? Dublino?
Esatto.
Loro sono curdi però di origine.
Prego?
Erbil, in Kurdistan.
So it's time to declare that the graduate Zainab Raouf has fulfilled all the requirements for the master's degree with the comprehensive final grade of 90 out of 110. And by virtue of the authority vested in me by the Italian law, I confer her the master's degree in medicine and surgery and license to practice. Congratulations.
Brava.
Grazie. Grazie.
Complimenti.
Complimenti. Abbiamo... And he will discuss the first of two theses with Professor Pappone. The title is Long-Term Outcome Following Epicardial Catheter Ablation of the Arrhythmogenic Substrate in High-Risk Brugada Syndrome. Professor Pappone, please.
Good morning to everybody. Every year in all over the world, we have 4 million people die suddenly. And Brugada syndrome is, in most of the cases, the most important cause of sudden death. It is an inherited cardiac condition, And Alfonso did a great job in collecting data and results in the strategy of treating the substrate of this inherited condition. Please.
Thank you for the introduction, Professor Papo. Again, the main topic of the dissertation I'm about to introduce to this honorable Google panel consists in the long-term outcome following epicardial catheter ablation of the arrhythmogenic substrate in high-risk Brugada syndrome patients. However, before jumping to the main topic of the study, it is relevant to introduce the main characteristics of Brugada syndrome and its interconnection to sudden cardiac death. Indeed, sudden cardiac death represents an unfortunate outcome for a variety of different pathologies, and by considering its epidemiology, its incidence has been considered in the range of 4 to 5 million cases per year. The vast majority of these cases are due to coronary heart diseases. However, a relevant piece of the cake is being shared by inherited arrhythmias. Among inherited arrhythmias, we categorize Brugada syndrome, that we define as a genetically based heart disease associated with an increased risk of sudden death due to potentially lethal ventricular arrhythmias such as ventricular tachycardia and ventricular fibrillation. This is a fundamental aspect, as ventricular fibrillation are arrhythmias that nowadays we treat through radiofrequency ablation of the arrhythmogenic substrate inducing them. As such, in the context of Brugada syndrome, through the ablation of the arrhythmogenic substrate, we may be able to reduce the occurrence and the recurrence of ventricular tachycardias and ventricular fibrillation, which act as sudden cardiac death in these patients, which are otherwise healthy and young. By considering the data gathered in San Donato, we may say that the first clinical presentation of patients affected by Brugada syndrome is characterized by a very heterogeneous panel. Indeed, we may see that 14% of them may present with cardiac arrest, 36% with syncope, 21% with palpitations, and 29% of the cases are even asymptomatic. Again, this is another important thing to understand the fugacious nature of this pathology, that, however, may be discovered by considering other conditions associated or connected to it. Indeed, analyzing the data in San Donato, we have seen that there are many arrhythmias concomitantly present to Brugada syndrome. Indeed, in 25% of the cases, there may be presence of atrioventricular nodal reentrant tachycardia, PVCs. 24% of the cases, atrial fibrillation. And in other percentages, other different arrhythmias, such as atrial flutter, Parkinson White. This is important as they act as warning markers of the presence of Brugada syndrome and may be considered as the proper symptoms of the pathology, whereas sudden cardiac death and cardiac arrest may be representing the worst clinical manifestation. Another important aspect to underline the fugacious nature of Brugada represented by the variety of phenotypic modulators that alter the natural history of the pathology. All of these factors, high temperature, low temperature, drugs, alcohol consumption, hyperglycemia, and heavy meals, are all factors capable to unveil the phenotypic manifestation of the pathology, inducing ventricular fibrillation in patients affected by Brugada syndrome. Hence, it appears that this pathology needs to be diagnosed and needs to have a proper diagnostic procedure in order to not miss any patient that is otherwise subjected to sudden cardiac death. We diagnose Brugada through electrocardiogram. It is suggested to place the right precordial leads up to the second intercostal space. This is done in order to increase the sensitivity of the means in detecting the typical electrocardiographic picture of Brugada syndrome, which is defined as a covert-type ST segment elevation with an J-point elevation above 2 millimeters of the isoelectric line. We did so in order to have a better resolution of the right ventricular outflow tract, which is the area where presence of the arrhythmogenic substrate. Indeed, the arrhythmogenic substrate is the determinant of the typical electrocardiographic picture in Brugada syndrome, both in type 1 Brugada pattern, which is the covert type ST segment elevation, as well as in type 2, as we may see from this slide, where we have two representation of the substrate. It is fundamental, however, in any case in which the electrocardiographic picture is not diagnostic to, as for example in TEP 2, or a completely normal electrocardiographic picture, however, associated to a clinical suspicion for the presence of Brugada syndrome, to perform a class 1 antiarrhythmic drug challenge, and in San Donato Hospital it is done through Ajmadin challenge, which is fundamental as it is capable to, as we may see from the left picture, unveil not only the electrocardiographic pattern of Brugada syndrome from a normal aspect in baseline to a type 1 Brugada pattern. But as we may see from the electroanatomical reconstruction on the right, it is capable to let the complete unveil of the substrate, as it is testified by the increase in its substrate area, as well as in increase in the abnormal behavior of the electrograms that characterize the substrate. Given that, there are three aims in this study. First of all, investigate the methodology and the feasibility of epicardial mapping and ablation of the right ventricle. Then, report the safety and the efficacy of radiofrequency ablation of the Brugada syndrome arrhythmogenic in the largest cohort of consecutive Brugada syndrome patients with various clinical presentations. Finally, describe the short and long-term results of epicardial ablation in terms of ECG pattern normalization and prevention of life-threatening ventricular arrhythmias. We did so by enrolling 885 patients, furthermore subdividing them into different groups by considering the specific indication to ICD implantation in these patients, as the ICD implantation by Brugada syndrome defines a high-risk patient. Furthermore, we divided Brugada syndrome. In group 1, we enrolled all 406 patients whose indication to ICD implantation consisted in the presence of typical Brugada syndrome-related symptoms. Furthermore, stratifying them according to their clinical presentation. In worse clinical presentation for all the 145 patients that presented with a primary test, and in not worse clinical presentation for all those 261 presenting with a syncope and a documented arrhythmia. On the other hand, in group 2, we enrolled 479 patients whose indication was not Brugada syndrome-related symptoms, but was the presence of inducibility at the electrophysiological study, altogether with symptoms that may be attributable to ventricular tachycardia, ventricular fibrillation, but without any documented arrhythmia. Before the ablation procedure, all patients underwent a combined epiendocardial mapping procedure. In order to perform so, we needed to access the epicardial aspect of the heart. We did it through a percutaneous subxiphoid puncture, and we have here a video describing it. Here is the puncture. After we see that it is penetrating the pericardial aspect, which is a bit more dark as it has been excreted some contrast means. Then there is a guide wire that turn around the heart in order to have the idea that we are in space, after which we introduce a steerable sheet through which we maneuver the catheter. Given that the proper mapping procedure starts, and what do we map in the epicardial aspects are the electrograms. Electrograms that we expect in a patient affected by Brugada syndrome are the one that we see in the bottom panel. They are clearly different from the electrograms that we see in the up panel, where there are, which are shorter than 110 milliseconds, differently from the one in the bottom panel, and don't present any delayed or component. The result of the mapping procedure will be consisting in a potential duration map created through the CARTO system. This is perfectly representing the onion-like behavior of the substrate of Brugada syndrome. Indeed, different arrows are different electrograms taken at different points of the substrate. How the purple arrows are describing much more abnormal electrograms in comparison to the light blue arrow and the red arrow. Moreover, it is important to underline how far, the more we reach the center and the core of the substrate, the more will be abnormal the behavior of the electrogram. Indeed, the purple arrow describing the core, the central point, is more abnormal than the purple arrow that is taken slightly less in the core, which are much more abnormal than the light blue arrow that is delayed but doesn't present such a the double and discrete component. Furthermore, the different from the red arrow describing a point outside of the substrate and hence having a completely normal electron. After the mapping procedure, we proceeded to perform the ablation procedure to all patients. And here we have a video describing it. It is interesting to underline the presence of the catheter in the core of the substrate. The radiofrequency is applied. After radiofrequency is applied, after a few minutes, it is interesting to underline how there's a change in the ST segment elevation of the patient. The typical COVID type ST segment elevation and at the end of the procedure will be a flat ST segment elevation that is not due to the persistence of the pathology, but is consequent to the presence of inflammation. When such inflammation will subside, there will be no persistence of Brugada pattern from the video, both before and after Ajmalin challenge. And this is another representation of our results. Indeed, we have two different electroanatomical maps of the same patients, both before and after the ablation procedure. The catheter is taking a point in the same, is taking an electrogram in the same point of the epicardium of this patient before and after the procedure. What do we see is that before the ablation, the patient presents a very abnormal electrogram, greater than 300 milliseconds. The same spot after the procedure is characterized by complete absence of abnormal electrical activity. Hence, our results were very successful. 100% of patients didn't show spontaneous or drug-induced Brugada type 1 ECG pattern during the follow-up and were not inducible at the electrophysiological study at 3, 12, 18, and 24 months. Moreover, at the interrogation of the ICD, neither of them showed recurrence of ventricular tachycardia. In only 3 patients that were very complex and had a prior cardiac arrest and a very large there was necessity to perform a redo mapping and ablation procedure, and also for them, after the redo procedure, neither spontaneous or drug-induced Brugada pattern was occurring. Recurrence of ventricular fibrillation was documented in only 2 patients due to concomitant arrhythmogenic right ventricular dysplasia, and complications related to the procedures were very shallow in their rate. Indeed, only 15 patients manifested pericardial effusion, and pericardiocentesis was required and performed in only 7 patients. Moreover, no other patient experienced any major complication. Given that, we may say that our results embody the vision that the arrhythmogenic substrate acts as the main driver of the natural history of Brugada syndrome. Indeed, it is the cause and the main determinant of the abnormal electrogram duration, of the patients at the electrophysiological study, of the occurrence of potentially lethal ventricular arrhythmias, of the specific electrocardiographic picture, of the clinical manifestation, and, unfortunately, of the unfortunate family history of many Brugada families. In this context, the epicardial ablation of the arrhythmogenic substrate in Brugada syndrome, as our results prove, may represent an effective strategy in preventing recurrence of ventricular tachycardia and ventricular fibrillation in those patients. Furthermore, reducing also the need for ICD therapy, with only a very shallow risk of major complications. As such, one may envision that in the near future, the ablation of the arrhythmogenic substrate may be representing a readily available alternative in the implantation of ICD without having the same physical and psychological consequences. Before concluding, I want to thank Professor Carlo Pappone and Professor Ciconte and the whole team at the ACC Policlinico San Donato Arrhythmology Electrophysiology Unit. Without you, I wouldn't have been. Thank you very much.
Professor Pappone.
It's interesting how Alfonso became so familiar with these very complicated stories. And I am very surprised to listen to your presentation, because you are not just did the memory of the thing. Giuseppe, what you comment?
Alfonso, congratulations for having such a great job. great presentation, and I'm very happy to listen your presentation. You know, Brugada syndrome has been recently described, let's say, 20 years, and unfortunately, this was considered a pure electrical disease. The idea that was an arrhythmogenic substrate or abnormalities in the heart behind this, it is such a novelty that may envision, as you said, new perspectives, new concepts in the treatment of this disease. So, but the main concept is that patients with Brugada syndrome may die suddenly. They are happy living their life, and the first event might be the last. So, what you elaborate on this. Is there any chance that we can use this for re-stratification on this patient, and how this is the genetic architecture, because we don't forget that is also a genetic disease. So what is your opinion about that?
Indeed, as our results prove, the arrhythmogenic substrate is fundamental in the natural history of the pathology, and its size is a very important prognostic factor in understanding the natural course of the pathology in given patients. And there are many studies that testify how the larger the substrate, the greater is the risk of a given patient to undergo ventricular fibrillation, ventricular tachycardia. Furthermore, underlining how the larger it is, the more dreadful is the arrhythmic manifestation. And the largest most probably will be giving a cardiac arrest, ventricular fibrillation or a polymorphic ventricular tachycardia. So just to finish also medical aspect, genetics in Brugada has a low yield of diagnostic relevance. However, as many other studies from San Donato group have been proven, the role of genetics, in particular for the loss of function mutation of SCN5A, is fundamental for the prognostic aspect of the pathology.
Bene, thank you so much.
Thank you very much. Thank you very much.
Potete accomodarvi di là. Prego. No, figura.
Praticamente un pizzetto. No, sì, è proprio acceso, sì, Yes. Before. Troppo avanti. Already, yeah.
Io non lo conosco e
Ok. Bene. I declare that the graduate Alfonso Riccio has fulfilled all the requirements for the master's degree with the comprehensive final grade of 110 out of 110 and special mention. And by virtue of the authority vested in me by the Italian law, I confer him the master's degree in medicine and surgery and license to practice. Congratulations.
Thank you very much.
Questo ti tocca, mi dispiace, ma...
Grazie mille.
Complimenti, complimenti. Congratulazioni.
Facciamo una foto con la commissione.
Perfetto, grazie. Complimenti. Adesso abbiamo Federico Romani? Federico Romani. Molto bene. Yes, please. Now we have Federico Romani. We're discussing a thesis on role of omics in diagnosis and prognosis of Brugada syndrome. Professor Carlo Pappone and Emanuele Bicaldo. Please.
Is really a talent. He's extremely intelligent, and I think in the future he will do very important things.
Please. So good morning, everybody. This is my thesis on the role of omics in diagnosis and prognosis of Brugada syndrome. So before presenting our study, I'd like to give you some background on Brugada syndrome so that all of you can understand that
We had this already.
Sorry?
Già l'hanno spiegato.
Why we chose exactly. Okay, so you already know that the characteristics, the clinical characteristics, and the pathogenesis of Brugada syndrome, and the treatment as well, as we talked about before. I would like to just expand a bit on the genetics of Brugada syndrome. In fact, some experts still consider this condition to be a Mendelian disorder, as we said before, although multiple pieces of evidence have disproven this model. In fact, the screening for SCN5A, molecular confirmation of the diagnosis, of the clinical diagnosis without any testing, only in around less than 25% of. And even in our center, in which we employ next generation extended panel, including also genes that are not universally accepted as associated with Brugada syndrome, we yield a result of less than 50% of positive confirmations. A peculiar feature of Brugada syndrome is also the role of environmental factors, which increase the phenotypic appearance of disease and can be a trigger for sudden cardiac death, in particular with fever, alcohol, circadian cycle, autonomic function, drugs, and heavy meals. So knowing this, our two main study aims were to find evidence of a systemic metabolic impairment in Brugada syndrome due to all of the evidence that led us to think that this is, a disease with at least a metabolic impairment, and to develop a biomarker set able to screen patients in a cheap, fast, and non-invasive way with a higher sensitivity and specificity compared to current screening. In fact, we have seen with Alfonso Ricci's thesis that we have found a cure for Brugada syndrome for the first time. However, we still need a screening test to screen for the general population of this Brugada syndrome, as again, the first clinical presentation can be sudden death. So our study design was based on the multi-omics approach. This methodology implies analysis of multiple omics. In this case, we used metabolites, lipids, proteins, mRNA transcripts, and genes. However, as you might notice, this order is inversed, actually. Usually we start from genome. However, in our case, for two reasons, we decided to go for an inverse approach. First, simply using the genome alone, so whole genome sequencing studies have shown that these studies are very limitative in Brugada syndrome. And second, because our hypothesis was based on the fact that this is a metabolic syndrome. So we wanted to start with a metabolic, confirm our results with transcriptome and genome. And here is the flowchart of the study design. We started with 600 peripheral blood samples from 600 patients during hospital stay. In particular, all of these patients underwent Ashman testing. And so the 300 controls had no Brugada, confirmed by the fact that the Ashman was negative. And 300 Brugada patients were instead diagnosed with Ashman testing. In all of these 600 samples, we used the integrative analysis, multi-omic analysis, such as the one that we just explained. And then we applied statistical analysis, which will be better described later on in the presentation. So what we found during the first phase of multi-omics analysis were the lipids, metabolites, proteins, messenger RNAs that you can see here on the left. And in particular, we found that of these, the differentially expressed, accounting for a false discovery rate of 5% or 0.05. were 266 lipids, 365 metabolites, 25 plasmatic proteins, 995 cellular proteins, and 7,086 mRNA transcripts. Then we focused on our statistical analysis on lipids, proteins, and metabolites, as we wanted our biomarker to set to have these. And in particular, we checked the statistical importance and frequency through these 6 methods, as you can see, of multivariate machine learning, univariate variable importance. To select important informative features, we used sparse partial least square discriminant analysis. And in particular, we found that 330 features were predicted consistently among all 3 multivariate machine learning methods, so support vector machines, partial least square discriminant analysis, and random forest. And then these 330 commonly selected features from the 1,561 features previously found were additionally filtered through first selecting only the features that had an R curve above 0.6, and then by applying a sparse PLSTA, which is to rank these features. And in total, we found 13 features to be filtering. Then we refined this score set by noticing through cross-validation that the 13 compound set had the same accuracy of 76%, as you can see from the 2 curves, as the 10 compound set. So we discarded 3 of these compounds because they had no effect on the accuracy. And this is the biomarker set. As you might notice, it has actually 16 features instead of 10. This is because when also analyzing for male and female gender, we noticed that these patients were these sets were more accurate. The extended set with 10 core features plus 6 additional features was more accurate than the core set alone. And here you can see the overall rank based on both univariate and multivariate analysis that are under the curve and the logarithmic p-value. In total, we found 12 proteins, 2 metabolites, and 2 lipids. In order to verify the diagnostic value of these 2 sets, we then implemented Monte Carlo cross-validation. This technique is a way to have out-of-sample analysis without needing new subjects or samples. In fact, it works by training the AI with a part of your set, in our case 1/3, which was the holdout set, and then generating new data to test your hypothesis. It's very used among machine learning statistical analysis. And then the results were calculated again through support vector machine, partially squared discriminant analysis, random forest, and the logistic regression. This method was used both on general population as well as in subgroups, in particular with patients with history of sudden cardiac death, with family history of Brugada syndrome itself, without the pathogenic mutation in SCN5A, in males and females, in asymptomatic patients, and in young and old patients. The results for the cross-validation were these. As you can see, the extended set is a bit more accurate than the normal set. The pink line is the line for the holdout sample, the comparison, which is less accurate. As you can see, it's not very linear, while the Monte Carlo cross-validation is the blue area, which is said is more linear because it is done through 100 runs of Monte Carlo cross-validation, so a bigger sample set. Then, as we said, we applied the same validation on different subgroups, and I would say the most noticeable thing is that compared to all samples, the most interesting thing is that the extended set, according to logistic regression, is more accurate in patients without a family history, in patients that are asymptomatic, and in patients without SCN5 mutations, as well as in young patients. So, in order to better understand how these proteins, metabolites, lipids, all together implicate a metabolic component in Brugada syndrome, this next section of the discussion will be dedicated to describing the function of some of these biomarker set components. The of Brugada syndrome, according to our analysis, was fibronectin 1. This is a major glycoprotein of the extracellular matrix, which binds to many molecules such as integrins, collagen, fibrin, heparin, aldosterone. And it has been demonstrated, as written there, that it is linked to fibrosis of the heart. And in our case, it was upregulated, and in particular, it was upregulated threefold in all patients which had ICD. But this will need further explanations. Then this is another upregulated compound, which is aldehyde dehydrogenase 3D1. As you might know, aldehyde dehydrogenase is a big class of enzymes which metabolize the aldehyde. So, for example, acetaldehyde, which is a compound resulting in the metabolism of alcohol. So it might explain why some of these patients have impaired the alcohol metabolism and die after consuming alcohol. And on top of this, this enzyme also plays a role in lipid peroxidation and oxidative stress, which is a common trend in market compounds. Then we have peroxonase 1, which is a liver-excreted glycoprotein involved in the handling of lipids and lipid oxidation in vessels, as well as scavenging free radicals. And here we have fumarate, which I would say is one of the most interesting findings, because we found that a lot of molecules inside the Krebs cycle or a tricarboxylic acid cycle were upregulated or downregulated to our experience. In fact, here are in green all of the proteins, and in blue all of the metabolites, which are in support of this, we have also a solid carrier family 5, which is a protransporter for ATP and ADP, and also together with him a closely related protein, which is BDAC, to be downregulated, and they are involved in the ATP-ADP metabolism in mitochondria. And here there is an interaction network of all the proteins and metabolites found to be associated with Brugada syndrome in our subjects. I'd just like to focus your attention on two downregulators, which are GOT2 and MDH2. And the interesting thing is that both of these proteins are crucial for mitochondria and as such for the NADH redox balance. And I think not randomly, they are connected to a lot of metabolites as well. Finally, here we have the transcriptomic results telling us that the main pathway is altered according to the TOG algorithm and then to the Kyoto Encyclopedia of Genes and Genomes pathways database. Most dysregulated pathways in Brugada syndrome are transcription, translation, steroid biosynthesis, DNA repair, immune function, and non-alcoholic disease. And here are some of the preliminary genomic results. It might be said that there are no controls yet. However, from the results that we have from controls, it seems that the mutation frequency is much higher in Brugada patients. And here are the conclusions. Brugada syndrome does appear to be a Mendelian channelopathy from our results. However, it seems more like a spectrum of clinical conditions that are very heterogeneous and have metabolic involvement. And on top of this, we identified a specific biomarker set, including at least 10 proteins or 16, metabolites and lipids, differentially expressed in Brugada patients. Our biomarker set, more specifically, has found to have a diagnostic accuracy of around 77 to 85% according to the 10 and 16 compound biomarker set. And we think that further studies are warranted to implement the genomic data, which could explain more of our questions on these results, and to further validate this biomarker set as well, to assign a prognostic value to it, because as we saw, there might be a prognostic value as well. Thank you very much.
Thank you.
At the end of the story, Federico, we have the biomarker of Brugada syndrome. Yes. So this means that with a simple blood test, we can recognize the patient. Yes. What do you think?
I think it's groundbreaking because, I mean, I'm biased, of course, but it's the same as doing, for example, what we do for homocysteine nowadays. If we check for homocysteine and we're like, oh, okay, I'm at higher risk for cardiovascular events. Same for Brugada syndrome. One day we might have the same group of molecules that are tested normally, and the result will tell us if we're at risk of Brugada syndrome or not. And based on this, we might do more tests like Ashman testing or a Holter ECG to verify this risk, let's say.
Dr. Micaglio, the mentor of Federico.
Thank you very much, Federico. Thank you, Professor, for your beautiful presentation. My compliments. And I want to understand, to know your opinion about a possible new genetic testing for this condition.
Yes. So already I would say that there's already been a shift that I haven't been able to explain during this presentation, but there's already been a shift from Mendelian to oligogenic in the last few years, with also the proposition of a polygenic test score. So already there's a shift from a monogenic Mendelian disease to oligogenic. And that said, these genetic results, genomic results, when they're going to be done with also the knowledge that we collected from the protein metabolite and lipid analysis, we'll be able probably to extend this panel of genes, as we already saw actually. Okay.
Okay, thank you. No, it's not yet. It's not.
From very quick question.
Yeah.
Impressive data. Many congrats.
Thank you.
Very quickly, which is the cellular source of this metabolic?
Oh yes. So we analyze in particular plasma, as we said, or PBMCs, so peripheral blood mononuclear cells, because again, we didn't want to go, for example, for a single cell transcriptomic analysis on the tissue also, because it's not really ethical on Brugada patients, because nowadays the treatment is mostly epicardial for open heart surgery, so there's no way to do biopsy.
Your guess?
Which is my guess for
the cellular source.
I think most of these are coming from the liver, actually. I think there's a very strong, important source from the liver, but as well as the immune function, because we saw that a lot of cells from the immune function, exactly.
That's the reason why he was asking.
Yes, a lot of cells from the immune function. For example, some of the genes that we saw here.
No, it's okay.
Okay.
It's okay, it's fine.
It's okay. Thank you so much.
Thank you. Thank you.
In terms of time, how long do you think that we need to have the test ready?
For this thread to be ready, I would say it depends on the validation on the actual in vivo patients. Because for now, we've done only validation on the Monte Carlo cross validation, which is, yes, it's very accurate, but it's not the same thing as the real deal, I would say. We're opening up, can I say it? We're opening up a lab, professors opening up a lab around September, can I say it? Okay. Around September, that will try to speed up this process and eventually to commercialize the whole.
There is a biomarker, and the owner of patent is San Donato Group. So we are going to produce the kit for the assessment of the patient.
That's great. Yeah.
Good.
Thank you.
Thank you very much. Thank you very much. Okay. I declare that the graduate Federico Romani has fulfilled all the requirements for the market with the comprehensive final grade of 110 out of 110 with honors and special mention. And by virtue of the authority vested in me by the Italian law, I confer him the Master of Surgery and license to practice. Congratulations.
Cheese. Ah, ma non è necessario.
Niente, un attimo.
Tante vuote.
Grazie. Sarebbe meglio fosse vuoto. Ok. A questo punto good morning. Good morning. Nice. Morning. So Sipel today will discuss a thesis entitled Post-Planar Vitrectomy versus Parabolic in Young Patients. Marco Codenotti will introduce Sipel. Please, Marco.
Dear May, we are working. It's a very, very interesting work, and congratulations for patients involved in this work, more than 190 patients. It's very interesting for the vitreoretinal surgeons because I can speak about one of the biggest problems for the vitreoretinal surgeons, that is the retinal detachment in the young. Please, May.
Thank you for the introduction. Today I will be discussing vitrectomy versus sclerobuckle for young patients under the age of 40, discussing patients who underwent these surgeries for rhegmatogenous retinal detachment. When talking about retinal detachment is a medical emergency. When left untreated, the affected eye may lead to blindness. Retinal detachment occurs when there is separation of the neurosensory retina from the retinal pigmented epithelium. We can divide this into three types: exudative, fractional, and the one we will talk about today, which is rhegmatogenous retinal detachment, occurring when there is a tear or a hole in the retina that allows the vitreous gel to flow through and cause the retinal detachment. Risk factors include male gender, severe myopia, retinal tears, trauma, family history, connective tissue diseases, as well as complications from cataract. Symptoms are very important to understand because they are the most effective prevention, and risk reduction is to seek medical help as early as possible. These can include floaters, as can indicate a milder disease, and these can include a dense shadow that starts in the peripheral vision, or a sense of a veil or a curtain over the field, which may indicate a more severe disease. The purpose of surgery is to find all retinal breaks and seal them, as without treatment, blindness in the affected eye may result. The more conservative treatments include cryopexy, pneumatic retinopexy, and the treatment we will talk about today are vitrectomy and buccal surgery. Vitrectomy is the removal of the vitreous gel combined with filling of the eye with an internal tamponade. It can be gas, SF6 or S3F8, or it can be silicone oil. The common side effect of vitrectomy is the progression of cataract. Buccal surgery, on the other hand, is a lens-sparing procedure. It includes sewing of a silicone sponge or a band and tire to the sclera underneath the eye muscles. The band pushes the wall of the eye inwards against the retinal holes, sealing them. The study design is a retrospective study. This study used 100 files from the year 2006 to December 2020. We used the files from two different hospitals in Israel, Sheba Medical Center and Tel Aviv Swarovski Medical Center. Collection of the data included these following measures: male or female gender, the age of presentation, the type of surgery, if it's buccal, PPV plus minus cataract, or the combination of the two, the follow-up in month, the myopia status, the best corrected visual acuity, log MAR, as well as the status of the macula, on or off or partially off, the location of the retinal tears, inferior or both, the lens status on presentation, as well as the BCVA at each follow-up, at the second surgery, if was done and not, the final lens status, clear or not, and cataract surgery, if was done or was not. Our patients are from the ages of 0 to 40, underwent surgery for buccal or vitrectomy after RRV. The patients that we excluded are the complicated retinal detachment, as can occur with a giant retinal tear, previous intraocular surgery, as can occur with cataract or glaucoma, a history of retinal detachment in the same eye, as well as predisposing factors for RRD, such as retinopathy of prematurity, trauma, or a coexisting cataract. This is an important point to be made that all our initial patients had initial clear lens status at presentation. The difference in the demographics can be seen here. We took a total of 260 eyes of 260 patients. We followed them for a mean of 18 months, and the mean age was 28. As you can see, the female and male ratio was almost equal, and when we are looking at buccal compared to the PPV plus minus cataract population, we can see they are much younger. These were the most common operation. Buccal constituted 81.5% of our whole population. Additionally, they had better macula on rates in comparison and also had more inferior tears. When looking at the chart here, this presents the BCVA log bar, pre-surgery, 1 month, 1 year, and at the last follow-up. The bottom line presents buccal surgery. We can see that not only did they have the best BCVA at presentation, they also had a very nice linear regression in comparison to the PPV groups. This increase in BCVA seen at 1 month is expected, as in this point they still have internal temperature silicone oil in their eyes, affecting their visual acuity, decreasing it. We can then see the improvement of their visual acuity. That being said, even at comparison of all surgeries, buccal surgery still had the best, better visual acuity and the better visual acuity gain. In terms of the gray line, this presents buccal plus PPV, and these patients were removed because of the small sample size, only presenting around 5.8%. Talking about visual acuity gain, we can see right here the gain. So we can see that an increased logMAR presentation or log visual acuity is a positive predictor factor for visual gain. Additionally, buccal versus vitrectomy had better gain. When looking at complications, we have 2 major complications we can look at: cataract development and the tendency for a second surgery. As can be expected, buccal had less of cataract in comparison to the buccal plus PPV and the cataract group. Additionally, they only presented 4.2% of these buccal patients underwent cataract surgery in comparison to the around 50% of the vitrectomy group. This is again to be expected, as vitrectomy may lead to cataract. This is a common complication. On the other hand, it was interesting to see that in terms of second surgery, the buccal had a higher tendency of no second surgery in comparison to the PPV groups, and that the types of surgeries were more various in comparison to the PPV group, which only had another PPV as their second surgery. When looking at single surgery anatomical success, the primary success rate as only undergoing a primary surgery of a second surgery. While we did see a higher tendency in the buccal, 84% versus the vitrectomy groups, 63%, adjusting potential co-founders, we found between the 2 groups, buccal and PPV plus minus cataract, in developing a second surgery. We did find marginally predictive negative predictor factors, including older age and a low visual acuity on presentation. Additionally, we looked at myopia and macula on-off status, and these have not shown to be independent risk factors. The limitations of our study is that the study is a retrospective study with multiple centers, leading to generalization of the results. This model was also conducted on a small sample size of patients that underwent second surgery, small sample size that went buccal plus PPV, only presented 5.8%, and a significantly smaller number of patients who underwent PPV compared to the sclerobuccal group, which presented 81% of our patients. Additionally, vitrectomy may be combined with cataract in a clear lens status. This obviously will increase the complications. And this was done in one of our centers. And of course, preference and their own abilities and experience in each surgery is an important limitation. Conclusion. The scleral buckle had better status, higher visual acuity gain, improved visual acuity in comparison to PPV, done alone or in combination with cataract at all follow-ups. Additionally, cataract development and surgery were lowest in buckle. Lastly, when predicting a second surgery, it was found that among the older patients or patients were above the age of 30, as well as patients with poor initial visual acuity, there was a higher probability of second surgery, and after adjusting the potential confounders, no difference was found between the PPV group and the buckle group in predicting single surgery anatomical success. Very much for Professor Francesco Bandello and Professor Marco Codinetti of San Raffaele University and Professor Adi El-Barak and Dr. Aya Balbilai of Tel Aviv's Watsky Medical Center.
Anat, why don't you say thank you to Anat first?
Anat?
Thank you. Thank you. So Marco, you want to make... yeah.
Congratulations, May, for your presentation. I would like to address just a couple of questions in relation to your research. Why do you think pathological myopia was associated with the lower risk rates of anatomical success in the buckling group, but not in the vitrectomy group? And what are the advantages of performing a retrospective study in multiple centers?
So in terms of pathological myopia, in our study, we actually found no statistical correlation between the two. While we know that pathological myopia does increase the risk of retinal detachment by 5 to 6 times, we also saw in previous studies, such as at Thellens et al.'s studies, that low myopia under -8 diopters have shown to be positive for anatomical success. This was not shown in our study, probably because of the small sample size of these patients. We had much less PPV and complicated patients in comparison to the myopia and high myopia status. In terms of the benefit of retrospective study, it gives real-life results. This not only gives real-life results, we also combined 2 different centers, which increases the number of surgeries done, increases the number of patients, increases the sample size, and that will indicate a more real-life field of results.
Other questions? The other eye doctors. Thank you. Thank you so much.
Thank you very much.
See you in a few minutes. A few seconds. You need to go.
E accediamo.
Ariel Barak. Ah, no,
non avevo capito se era già fatto come l'altro o...
Facciamo il mio web.
Sei pronta? Ready? Okay. I declare that the graduate May Silfen has fulfilled all the requirements for the master's degree with the comprehensive final grade of 108 out of 110, and by virtue of the authority vested in me by the Italian law, I confer her the master's degree in medicine and surgery and license to practice. Congratulations.
Just turn and then take a picture of the commission.
Thank you. Bye-bye. Thank you. Bye. Thank you.
Now we have Marta Boarino. She will discuss a thesis entitled Impact of
Remdesivir on SARS-CoV-2 experience in a real-life setting, a matched cohort study. We have Professor Antonella Castagna together with Vincenzo Spagnolo. So if you will introduce the candidate, please.
Yes, thanks. Remdesivir is the only drug, the only antiviral drug we have for SARS-CoV-2. It is approved under emergency of the pandemic, and the findings relative to these drugs are really controversial because the clinical benefit is not assured. It depends on what trials are you dealing with. And we have limited data on the antiviral activity of this drug. We have something on models, animal models, but not in the clinic. And I really appreciate the commitment of Marta in trying to collect all this data, all the retrospective data, evaluating the possible inhibition of viral replication by remdesivir. Marta?
Good morning, everyone. Thank you for the introduction. So today I will talk about the impact of remdesivir on SARS-CoV-2 virus. As we all know, since 2019, SARS-CoV-2 infected over 173 million people and caused almost 4 million deaths worldwide. The rapid surge in the number of cases put a great strain on the healthcare system worldwide, urging governments to implement containment strategies and the scientific community to find effective treatments. Currently, the treatment of hospitalized patients is based on support therapy with supplemental oxygen, drugs such as corticosteroids, antiviral drugs, and thromboembolic prophylaxis. The only antiviral drug approved so far by both FDA and EMA is remdesivir. Remdesivir is a nucleoside analog which was in October 2020 through an expedited process known as emergency use authorization, based on the evidence available at the time. In Italy, remdesivir is administered in agreement with the IFA criteria, exclusively to hospitalized patients with a documented COVID-19 pneumonia requiring oxygen therapy, who had symptoms onset within 10 days. The IFA criteria excludes patients requiring high-flow oxygen therapy, mechanical ventilation, or support. Eventually, several studies demonstrated that remdesivir did not reduce in-hospital mortality. But what about viral clearance? Viral clearance is defined as the process leading to the disappearance of viral RNA from all bodily fluids. Even though studies in literature demonstrated an association between viral load and disease severity, evidence regarding the impact of remdesivir on viral clearance is scarce. Therefore, our primary aim was to study the impact of remdesivir on viral clearance by comparing time to viral clearance within 30 days from hospital discharge in COVID-19 patients who received remdesivir and those who did not. Moreover, we analyzed the proportion of patients who received viral clearance. We studied the cycle threshold variations between the two groups during follow-up and evaluated the clinical and safety outcomes related to remdesivir administration. We conducted a retrospective matched cohort study, including patients hospitalized at San Raffaele Hospital from February 2020 to April 2021, with laboratory-confirmed SARS-CoV-2 infection on admission, evidence of severe pneumonia, and at least one follow-up nasopharyngeal swab. The viral clearance was considered to be reached with the first negative nasopharyngeal swab. The follow-up began from the date of the first positive nasopharyngeal specimen collected during hospital admission and lasted until death, negativization, or 30 days post-discharge, on whichever event occurred first. The nasopharyngeal swabs were analyzed exclusively using real-time PCR. The real-time PCR can yield two types of results, either qualitative or semi-quantitative ones. Qualitative can be either positive or negative, whereas the semi-quantitative ones are expressed as cycle thresholds. The cycle threshold values represent the number of amplification of a targeted viral gene required to reach a positive result. Therefore, lower CT cycle threshold values are associated with a higher viral sample. The distribution of continuous variables between the two groups was compared with the Wilcoxon-Rank-Sum test, whereas categorical variables were analyzed with the chi-square and the Fisher-Exact test. Time to viral clearance between the two groups was estimated with Kaplan-Meier curves and compared with log-rank test. Our study included 648 hospitalized patients. 216 of those received remdesivir and were considered cases, whereas the remaining 432 did not receive remdesivir and were considered controls. Cases and controls were matched based on age, sex, and PaO2 or PaO2 on admission in order to avoid confounders in the study design. The two study populations were comparable regarding age, sex, body mass index, number of comorbidity, severity of the disease on admission, and median follow-up time. Viral clearance within 30 days post-discharge was reached by 75.6% of patients in a median time of 25 days. The overall probability of viral clearance was similar between cases and control. Here we can see remdesivir users in red cases and controls who did not receive remdesivir in blue. However, when considering time to viral clearance according to the use of remdesivir and age, the highest proportion of negativization at 30 days from admission was seen in younger patients who were administered remdesivir. Same thing goes for when considering time to viral clearance according to remdesivir use and respiratory function. The lowest rate of viral clearance was observed in the group of patients with more severe disease on admission who did not receive remdesivir, when compared to the subgroup of patients with severe disease who received remdesivir. In agreement with these results, also when considering exclusively those patients who reached viral clearance, the administration of remdesivir evidenced an increased probability to clearance in patients with disease. Then we analyzed the cycle thresholds variation. Data regarding variations in CT values were available for 83 patients. The median difference between the first and last CT values was greater in the remdesivir group. Here we can see 6.7 increase in CT values when compared to 3.5 in the control group. As a secondary endpoint, we studied clinical and safety outcome of remdesivir administration. So even though there were no differences in terms of mortality or ventilation initiation, the administration of remdesivir was not associated to complications when compared to controls. Therefore, we confirm that remdesivir is a safe and manageable drug. In conclusion, despite the overall probability of obtaining viral clearance being similar between patients receiving or not receiving remdesivir, remdesivir was associated with a higher rate of viral clearance in younger patients and in those patients with a more severe pneumonia. Therefore, these criteria may be useful in identifying those subjects who could benefit the most from remdesivir administration. Moreover, remdesivir was associated with a greater increase in CT value compared to the control group.
and is a safe and manageable drug feasible in the treatment of hospitalized patients with severe COVID-19 pneumonia. This work has been possible thanks to the enormous contribution of all the work involved in the care of COVID-19 patients. Our gratitude goes to all the clinicians, researchers, and statisticians of the COVID BOB study group. Thank you for your attention.
As you said, currently, all the approved drugs for the treatment of hospitalized patients with COVID-19. What about newer and investigational antivirals? Can you provide some
At the moment, there are several new antivirals which are under investigation. Examples are favipiravir or aerosolized ribavirin. However, one of the drugs which I think could be more promising is molnupiravir. Indeed, there was a late studies performed by Painter et al., where we could see that the of molnupiravir in just 5 days would completely reduce the viral load. Indeed, they did not find after 5 days any viable virus in the samples, whereas the control group, this was a randomized control trial, at the moment they're just at the phase 2. The placebo group showed that 24% of viable virus at 5 days. So I think it's a pretty impressive result, and it's worth continuing to see how it goes. Whereas the other antivirals, like favipiravir, are more considered in outpatient settings or hospitalized patients who do not need oxygen therapy. So I think the future aim of antiviral drugs will be to prevent COVID-19 to reach such a severe degree requiring hospitalization, whereas in the meantime, remdesivir remains the only viable option in hospitalized patients.
Other comments?
Thank you, Matt.
Thank you. Thank you. See you.
Metti il tuo cappello. È vero. Il tuo cappello te l'ha fregato così.
Così mi riconoscono per la calvizie, capito? Quando sono filmato, eccetera. E quello. I declare that the graduate Marta Boarino has fulfilled all the requirements for the master's degree with the comprehensive final grade of 110 out of 110 with honor and special mention. And by virtue of the authority vested in me by the eternal law, I confer her the master's degree in medicine surgery and license to practice. Congratulations.
Grazie.
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 Congratulazioni. Arrivederci, congratulazioni, arrivederci. So, ora chiudiamo in bellezza veramente. So, last but not least, in cauda venenum, they said many years ago. We have Belluardi. We present the thesis on beta cell lymphomas and marginal zone origin, diagnostic impact of MNDA in the recognition of primary nodal subtype. Professor Maurizio Ponzoni and Lucia Bongiovanni will discuss the thesis. Please, Maurizio, if you want to introduce the candidate.
Yeah, thank you. It's a great pleasure to introduce you, Salvatore, who has been an excellent student throughout all the course, and he took a very high risk to discuss this thesis because it's very difficult task because we don't know so much about this rare type of lymphoma. So please, Salvatore.
Okay, so good morning, everybody. The topic of my thesis is the diagnostic value of the myeloid cell nuclear differentiation antigen in the recognition of a specific subtype of marginal zone B-cell lymphomas, that is the primary nodal subtype. According to the latest WHO classification of lymphoid neoplasms, the group of marginal zone lymphomas, three different entities. There is the extranodal lymphoma, which is the most common entity, and it accounts for around 70% of cases. Extranodal marginal zone lymphomas, in the vast majority of cases, are right intestinal tract. Although other common sites that are listed in decreasing order of frequency are the ocular annexa, the skin, lungs, salivary glands, breast, and thyroid gland. The second most common entity is instead represented by the splenic type, which accounts for 20% of cases, and the less known entity is instead the nodal marginal zone lymphoma, which accounts for around 10% of marginal zone lymphomas and approximately 1.8% of non-Hodgkin lymphomas. Antigenic drive is extremely important in the pathogenesis of these disorders, and it is played by infections such as bacteria and viruses, as well as by autoimmune disorders. The clinical presentation of marginal zone lymphoma is highly variable, and it depends on the specific subtype being considered. Starting with the extranodal marginal zone lymphoma, we should remember that in the vast majority of cases, patients present with a stage 1 or a stage 2 disease. Signs and symptoms are obviously broadly variable, and they depend on the specific subtype being considered, and the 5-year overall survival is really good, and it is between 86 and 95%. With regard to the splenic marginal zone lymphoma, instead, given the high frequency of bone marrow and liver involvement, patients generally present with a stage 4 disease. Autoimmune manifestations such as anemia and thrombocytopenia can be present as well, and in this case, the 5-year overall survival is about 80%. Lastly, in the case of the nodal marginal zone lymphoma, patients might feature any stage of disease at presentation. Anemia and thrombocytopenia can be present as well, and in this case, the 5-year overall survival is lower if compared with the two previous entities. It is crucial to remember that around 30% of nodal marginal zone lymphomas may actually represent the nodal dissemination of an extranodal marginal lymphoma. This is the reason why, nowadays, the diagnosis of this entity it is still based on clinical and instrumental criteria. We decided to study in greater details the nodal marginal zone lymphoma, which is the least known entity. Unfortunately, the pathogenesis of this disease it is not known, and probably an antigenic drive might be implicated in lymphomagenesis, at least in some cases. In addition, different series show heterogeneous results in terms of clinical and molecular feature. This is the reason why it is not clear whether this entity, whether the nodal marginal zone lymphoma might represent a single entity or multiple entities. In addition, the diagnosis of this entity it is still one of the remaining diagnostic problem areas in hematopathology, given the lack of exclusive positive immunohistochemical or molecular markers. Accordingly, the differentiation of nodal marginal zone lymphoma from other indolent B-cell lymphomas it is often challenging, and sometimes it is really impossible. This is the reason why we decided to study the expression of MNDA in nodal marginal zone lymphoma, which is a newly proposed marker for marginal zone lymphomas. So the myeloid cell nuclear differentiation antigen, it belongs to the interferon-regulated 200 family of proteins. And although expression was initially thought to be restricted to the cells of the myelomonocytic lineage, several studies provided evidence that this protein is also expressed by marginal zone B cells of the splenic white pulp, tonsils, and reactive mesenteric lymph nodes. MNDA expression has also been reported in a large series of B-cell lymphomas, both indolent lymphomas and aggressive lymphomas, we can say. And the expression of this marker is particularly present in marginal zone lymphomas, whereas MNDA, the expression of MNDA is really restricted in the case of follicular lymphoma. This is the reason why MNDA is a really useful immunohistochemical marker when needing to differentiate between marginal zone lymphomas and follicular lymphomas. So in our study, we define as inclusion criteria lymph node biopsies of at least 1 centimeter in diameter and no evidence of previous treatment. We then performed an immunohistochemical staining for MNDA using a rabbit polyclonal antibody, and samples were scored as positive based on a cutoff value of positivity of 20%, and this value has already been published in the literature. We then analyzed the MNDA architectural distribution, and we classified samples as interfollicular, diffuse, mixed, and thick. So, notwithstanding the rarity of this entity, we have been able to assess the expression of MNDA in 19 samples of marginal zone lymphoma, which is actually a relatively high number of cases. As controls, we then selected 10 samples of the ocular annexa marginal zone lymphoma. Among these 10 samples, 6 were positive for Chlamydia pistachi, whereas the remainder 4 were negative for the presence of this bacterium. As we can see from the pie chart on the left-hand side of the screen, 7 cases of the nodal marginal zone lymphoma had a percentage of MNDA positive nuclei that was in the range between 0 and 90%. Accordingly, these cases were classified as negative. Conversely, in the case of the ocular annexa marginal zone lymphoma, all samples had a percentage of MNDA positive neoplastic cells that was greater than 20%. So overall, we have found that the MNDA was expressed in 63% of nodal marginal zone lymphomas and in 100% of the ocular annexa marginal zone lymphomas. So we also demonstrated for the first time that MNDA is significantly more expressed in the ocular annexa marginal zone lymphoma compared with the nodal subtype. If we try to compare our results with previous studies, we can see that they are perfectly in line with the study of Canellis and also with the study of Wang et al. However, our results are in contrast with that of Metcalf et al. That reported a higher percentage of MNDA positive cases in nodal marginal zone lymphoma compared with the extranodal subtype. We also found that the mean value of MNDA positive neoplastic cells was well above the cutoff level of positivity in both cohorts. However, in this case, we did not observe any statistically significant difference. Given the absence of data in the literature, we also sought to establish whether the expression of MNDA could be related to Chlamydia pistachi infection status. However, in this case, we did not observe any significant difference. We should also, however, consider that in our study, we selected only 10 samples of the ocular annexa marginal zone lymphoma, and therefore, future studies that confirm our preliminary results are obviously needed. We then evaluated the MNDA architectural distribution in both cohorts, and we found that in nodal marginal zone lymphoma, follicular, diffuse, and mixed parents were found with exactly the same frequency. Conversely, in the case of the ocular annexa marginal zone lymphoma, the diffuse parent was the most prevalent, evident in 40% of cases. So in the first panel on the top left, this is a case of nodal marginal zone lymphoma scoring negative for MNDA. However, we can appreciate some cells that are MNDA positive. These cells are granulocytes, and they serve as internal control to verify the quality of the staining. In the diffuse parent, instead, we can see diffuse sheets of MNDA positive neoplastic cells. In the perifollicular parent, instead, these cells have a predominant follicular distribution. And lastly, in the specific pattern, as we can see, there was neither a clear diffuse nor a perifollicular. We then evaluated those samples for the possible presence of follicular colonization. Follicular colonization is a phenomenon that occurs when the neoplastic cells that are here depicted in light blue and are found in the marginal zone of reactive infiltrate and invade the germinal center. So these cells will then intermingle with residual germinal center cells. This is exactly what I've shown before. This is a case of nodal marginal zone lymphoma showing follicular colonization. So we can appreciate the germinal center, and inside the germinal center, we can see MNDA positive neoplastic cells. And follicular colonization is sometimes follicular colonization by marginal zone lymphoma is really difficult to be differentiated from a case of follicular lymphoma. Now, we can conclude saying that in our study, we have found that the expression of MNDA was significantly more common in the ocular annexa marginal zone lymphoma compared with the nodal marginal zone lymphoma. Our research suggests that MNDA is a really useful immunohistochemical marker when needing to differentiate between a follicular lymphoma and the follicular colonization by marginal zone lymphomas. Obviously, pathognomonic immunohistochemical markers for nodal marginal zone lymphoma must be sought in the near future, and this is extremely important in order to facilitate the diagnosis of this entity. And lastly, we found that our results basically suggest that MNDA is not useful when needing to differentiate between a primary nodal marginal zone for a true nodal marginal zone lymphoma and the nodal dissemination of an extranodal marginal zone lymphoma. This is the reason why, as I stressed during the presentation, the diagnosis of this entity must be on clinical grounds. I would like to end my presentation thanking all the pathology unit of our hospital. I must thank Stefano Grassi and Euclio Visco for their technical support. I'm grateful to Dr. Bongiovanni, Dr. Giordano Ressi, and Professor Claudio Doglioni, head of our pathology unit. Last but not least, our debt of gratitude to Professor Maurizio Ponzoni for his time, dedication to work, and careful attention to details. Thank you.
Professor Ponzoni, it's your turn now.
Yeah, I leave the word to Dr. Bongiovanni.
For presentation compliments. What do you think about the discrepancy of our results and study and that the extranodal marginal zone lymphoma can express of MNDA according to
so we have seen that our study is in contrast with that of Metcalf et al. These differences in data might probably be related to inclusion criteria that were used in order to define a primary nodal marginal zone lymphoma. Equally important, however, we should remember that in our study, we selected only a specific subtype of the extranodal marginal zone lymphoma that was represented by the ocular annexa marginal zone lymphoma. Conversely, in the study of Metcalf et al., extranodal marginal zone lymphomas were not classified according to their anatomical size, and we can probably even assume that they were selected across a spectrum of anatomical size, anatomical locations. And considering the fact that nowadays we are aware of the fact that extranodal marginal zone lymphomas are a really heterogeneous group, obviously we can expect that different types of extranodal marginal zone lymphomas might have a different expression of MNDA.
Thank you. Other comments? Questions? No, that's not the case. Thank you very much. We'll see you in a second. I know. Mi pare. Adesso c'è con Alberto in commissione. Alberto adesso.
Ma tu lo so che lo fai solo perché ci sono io.
Sì. Allora possiamo farli entrare se che dobbiamo fare il record.
Appena uscito. Metti un cappello per l'ultimo, dai. All'ultimo metti il cappello.
Questa roba di internet così era.
Devono riconoscerlo.
Devo mettere la musica.
E poi non c'è più la fase finale che si diceva, no? Allora se il tuo ti do un'idea, questa cosa un po' accademica tipicamente italica.
Allora,
una cosa mancava. Cioè, quindi.
What's going on there? Prego.
Ti boicottano, Presidente.
Cosa mi dici del presidente nuovo eletto?
Lo dico dopo.
I declare that the graduate Salvatore Belluardo has fulfilled all the requirements for the master's degree with the comprehensive final grade of 110 out of 110 with honor and special mention. And by virtue of the authority vested in me by the Italian law, I confer him the master's degree in medicine and surgery and license to practice. Congratulazioni. Il professor Ponzoni voleva ancora altro, ma non era possibile. Non c'era. Complimenti, congratulazioni.
Arrivederci. Bravissimo. Bravo, adesso fai la foto.
Adesso il Presidente dice
Ite missa est. Ehi, ite missa est.
Grazie a tutti.
Ciao, grazie. Ciao, grazie a tutti. Posso lasciare tutto?